Hello, good evening, everyone. Today we will continue our Harrison-based discussion series. In last class, we have studied about dementia. Then we have covered about pseudobulbar and bulbar palsy and last class. Today we will be discussing about aphasia and some parietal lobe disorders. So in pseudobulbar and bulbar palsy, we have discussed about dysarthria component also. And when we were talking about dementia, so there in Alzheimer's disease, we have also talked about aphasia, language issue, dysarthria issue also. So after completing all this, now we will approach to aphasia, how we can approach a language disorder, how can differentiate between dysarthria and aphasia, what are the various type of aphasia, how to distinguish Wernicke aphasia from a psychiatric issue, how to approach Broca aphasia, uh, and especially when it comes to Wernicke aphasia. Generally, it happens without weakness, and Broca aphasia most of the times is presented with weakness. So we will see all these things, how to approach and how to be clear cut. Hello, Madhu Manjari. Okay, is audio okay? Everyone, everyone, audio okay? So shall we proceed? So in today class is about aphasia. So what is aphasia? Aphasia is a language disorder. It is a language disorder. So now, what do you understand by the term language? What do you understand by the term language? Anyone in comment section? What do you understand by the term language? Hello, Venki. Hello, Badmanjiri. Hello, Dr. Vipul. So anyone, what do you understand by the term language? Anyone? What do you understand by the term language? So language is a way of language is a way of communicating. And now, generally, what we think that language is all about speaking. Suppose I'm saying to you that go to other room. I'm saying to you that go to other room. So it is a language. I am giving you command and you are following that command. So maximum time, what we think that language is by only that we speak in Hindi and English. Only that is language. But language has a broader picture. Suppose I am drawing a diagram here. Suppose if I draw a diagram like this, what you understanding? You are understanding there's a heart. So I am drawing the diagram and you are seeing this figure, and by seeing this figure, you are interpreting something. By seeing this drawing, by seeing this drawing, you are interpreting something. So it is also a form of language. Now, if I say to you, heart, you will interpret something. Then there is a some sound, and your brain will interpret this sound. Now, suppose if I do like this is also heart. This is also heart. But here I'm doing some body movements or body gesture. But still, by doing movement or body gesture, I am able to convey you the thing which I want to. So either by I'm drawing, either by some gestures, either by my verbal command, or either by I am speaking to you that way. But in all these four or five way of command, you are able to understand that he is trying to say something related to heart. So all of these, all of these are a form of a language. All of these are a form of a language. So it can be a gesture conveying something through some actions, or it can be by writing. By writing something, you can say, or by expression. We have seen many times ki आंख दिखा दी. Generally, to small kids, their mummy show them the eye. So what the baby feel कि हाँ सब कुछ गलत हो रहा है. So expression also. Yeah, good evening, Dheeraj. So expression is also a way of conveying something. So expression, gesture, writing, और क्या हो सकता है? Other is verbal form. Other is verbal form. You are saying something to someone. और क्या हो सकता है? It can be visual perception. And verbal is your speech. Verbal is your speech. So we can see that speech is only one of a part of a language. It is not all about language. Speech is not language. There are other forms of language, that is gesture, writing, expression, verbal part, visual part. So there are 4 5 components in language. So language is a broader term. Language is a broader term. Speech is only a one part of language. Okay. So these all is a language. So language is in a way of communicating a thing to some person by a different mood. And verbal or speech is one of that mood. Either it can be done by writing or some gestures, or can be a verbal, or it can be a visual. So this is about a language. So everyone has got the concept of language, and we have to know that speech is a motor part of language. Speech is a motor part of language because in our mind we are thinking something. Suppose in my mind I am thinking, I have to say a word. I have to say a word. Suppose I have to say a pen. I have to say a word pencil. So image of pencil has come to my mind. Okay, my brain has interpreted the word pencil, and through my larynx, through my pharynx, I am able to speak that word. That is pencil. So pen language, I have think something. But the verbal part of the language, the motor part of the language is speech. Because I am speaking pencil. So it is in a speech is a motor part of language. But I am thinking, I am knowing something. That is the other forms of language. So speech is a motor part of a language. Okay. So suppose I am seeing this, what I'm interpreting from this, I'm interpreting it is a pencil. So this pencil, this object is acting to me as a visual source. So by seeing this, my brain is interpreting something. So it is a visual form of a language. It is a visual form of a language. I am interpreting something, that is pencil. Now my brain has interpreted it as a pencil. Now I'm speaking to you. It is a pencil. So this is the speech part, and speech is a motor part of a language. Speech is a motor part of a language. Okay. Now there's also a term that your language is controlled by is controlled by your dominant hemisphere. Your dominant hemisphere. So what do you understand this term? That language is controlled by dominant hemisphere. In past time, what it was happening, when they are seeing the when scientists were seeing many patients of stroke, so they were thinking that some patients of stroke have more severe language issue as compared to other patients. They were thinking that some patients of stroke have a severe issue of language as compared to other. So when they found that the some patient of stroke who are having severe issue of language, and they noticed that it occurred also in a particular type of hemisphere. Okay, so what they have found that many individual which are having a left-sided stroke, many individual which were having a left-sided stroke, they were having more severe issue of language as compared to the patient who are having the right-sided stroke. So they call this part of hemisphere as a dominant hemisphere. They call this part of hemisphere as a dominant hemisphere. So when we are saying that is it a dominant or non-dominant hemisphere, we are only saying main thing about is the language. So your language is controlled by dominant hemisphere. So if your non-dominant hemisphere is damaged, then your language will not be impaired. Okay, that's why when they were seeing the patient, especially patient who are having right-sided stroke, they were seeing that they were having weakness, counter, but their language was not impaired. But when were they seeing the patient who are having a left-sided stroke, they were having weakness, but their language was very much impaired. So they call this concept as a dominant and a non-dominant hemisphere. When we are saying something as a dominant hemisphere, we are meaning that their language is impaired, and language is only impaired, or we can say maximum time it is impaired in dominant hemisphere. Okay, everyone, got this concept? Venki, Dheeraj, everyone. So okay, now what we see that patient who are right-handed patient, in them 90% time the dominant hemisphere is left side. Dominant hemisphere is left side. Then and in left-handed individual, 60% time dominant side is also left side hemisphere. It is left side hemisphere. So maximum time language issue is with dominant hemisphere, which is maximum time is your left side. Because in right-handed individual, 90% dominant hemisphere is your left side. And in left-handed individual also, 60% of the time, the dominant hemisphere is left side. Okay, everyone? Got this? Just give me a thumbs up if you have got this concept. Okay, dear. Now see, I have told you that speech is a motor part of a language. Speech is a motor part of language. And if speech which is in a articulation issue. So impaired, if speech is impaired, we call this as many times a dysarthria. It has a dysarthria. So in language, there visual, writing, gesture. Speech is one of them, and it's in speech, in speech, and in speech also that only a articulation issue there. In speech, a articulation issue is there. Then we call this as a dysarthria. What we call it as? We call it as a dysarthria. Okay, everyone. So we can say that language that language is an umbrella term. It is an umbrella term in which many things come. That is emotional gesture, visual, writing, seeing, listening to someone, and your motor part, that is speech. And if there is a problem in speech, artificial defect is there. It is called as dysarthria. Okay, everyone. Now see this. Speech, it is a mechanism of expressing thought and idea. What it is? It is an mechanism of expressing the thoughts and ideas. It can be by speech, we have done. It can be by writing, giving some graphic symbols. So speech is like I'm saying something. If I'm saying something by writing me, I'm writing, suppose I'm writing heart. So you are interpreting something by gesture or by gestures and motor symbols. If I'm doing like this, you are also understanding. Language may be regarded as many means of expressing or communicating a feeling through system and symbol. It is a function of your cerebral cortex. It is a function of your cerebral cortex. And that's also of a dominant side. That's also of a dominant side. Now see, he's saying They are talking. It is also mean of language. This guy who is holding hand, this guy who is holding hand, by holding hand, he is also trying to convey something, na? So that is also a way of communication. That is also a way of communication. Okay, Arjun? He's something writing. That is also a way of communication. Then it comes a visual. It is also a way of communication. So they all are a part of a language. They all are a part of a language. Now, so we have understood that language is in a broader term. It has various terms in this, and language is controlled by your cerebral cortex. We have got this, and basically we have also got this concept that what is do you mean by when we saying a dominant hemisphere, and what we are meaning when we are saying a non-dominant hemisphere. Language is the issue of a dominant hemisphere. Okay, now now we all have seen this diagram. That is your Wernicke's area. That is your Broca's area. Okay, Broca's area is number 44, and Wernicke is area number 22, and Wernicke is in superior temporal gyrus, and your Broca's is in inferior frontal. Your Broca's is in your inferior frontal. Okay, now what we can see this, what we can see in this, that especially Wernicke's, your Broca is area number 44, and Broca's is in frontal lobe. Okay, so FF 44, FF 44. When it comes to Wernicke's area, when it comes to Wernicke's area is in your temporal lobe. It is in your temporal lobe. So TT, it is TT, TT, it is your 22. Okay? So Broca's is in your frontal lobe, FF 44. Wernicke's area is in temporal lobe, TT, it is 22. So these two areas are the main areas of language in your cerebral cortex, and they both are connected by some white matter. They both are connected by some white matter. So can anyone tell me by which white matter both your Broca's and Wernicke's area are connected? Anyone in comment section? By which white matter tract your Broca's and Wernicke's areas are connected with each other? Anyone? By which white matter tract both your, yeah, but yeah, yeah, Shubhan, but what is the correct name? You are right. Something. No, no, no. I am asking the name. You are right, but I am asking the name. I am not asking the type of fiber. Yeah, anyone? Anyone in comment section? By which type of white matter thread both your Broca's and Wernicke's areas are connected with each other? Anyone? Shakuntala, Dheeraj, Venki, anyone? भाई ब्रोकर व्हाइट मैटर को कौन जोड़ता है आपस में? फर्स्ट ईयर एनाटॉमी क्वेश्चन। ब्रोकर और वर्निक को कौन जोड़ता है? हम्म। नो फेस्टिकुलस आर्टेरिटिस। नो हर्निक। भाई हमें नीट पीजी क्रैक करना है ऐसे कैसे काम चलेगा यार? भाई ब्रोका वर्निक को कनेक्ट कौन करता है? हम्म। ऐसे कैसे चलेगा? सोचो भाई, सोचो यार। भाई ब्रोका वर्निक से को कौन कनेक्ट करता है? क्या बोलते हो स्ट्रेट को जो ब्रोका से वर्निक को कनेक्ट करता है? योर फर्स्ट ईयर एन आर्ट फिजियो क्वेश्चन, सच अ सिंपल क्वेश्चन। एनीवन? Actuate? No, Shubham. What? No, beta. No. It is your. It is your arcuate fasciculus. It is your arcuate fasciculus which connects Broca's and Wernicke's area, beta. It is your arcuate fasciculus, which connects your Broca and. Oh, sorry, sorry, sorry. Wait a minute. Wait a minute. Which connects your Wernicke's and Broca area. Which connects your Wernicke's and arcuate fiber, arcuate fasciculus. Very good. Okay. Now, so see, this is a diagram. This is your Wernicke's area. Okay. And in inferior frontal is your Broca area. Broca is in frontal lobe, FF44, and Wernicke's is in temporal lobe, TT. See, temporal lobe TT, it is 22, which is your Wernicke's area, and Broca is frontal FF44. Done, and they are connected with each other. They are connected with each other with the help of arcuate fasciculus. With the help of arcuate fasciculus. Okay, everyone. Now, when now suppose I'm saying something to you. So I'm saying red. So when I'm saying something to you red, your ear are listening this word. Your ear are listening this word that is red, and now ear are communicating. Now ear is taking that information to your brain, and we all know that in our brain, especially your Wernicke's area, especially your Wernicke's area, it is used for understanding. It is used for understanding. It can be word or by seeing. It can be word or by seeing. Okay. That's why Wernicke's area is all about your comprehension. It is all about comprehension. So whenever you want to interpret something for a language purpose, whenever you want to interpret something for a language purpose, who is the who is the command center? It is your Wernicke's area. Now see, if I'm saying to you a word red, I'm saying to you word red, so your ears are listening, and this information is going to your Wernicke's area. Now this Wernicke's area is interpreting this word कि red का मतलब क्या है. Wernicke's area is interpreting this word. Okay. Other thing, suppose I am drawing a diagram. I have drawn this cube. I have drawn this cube. Okay. Now I'm seeing this cube by my visual area. By visual, I'm seeing this cube. And this visual information is going to my brain. And to my brain, it is going to Wernicke's area. And in Wernicke's area, it will be interpreted it as a cube. Wernicke area will interpret as a cube. So your visual and your auditory area has huge connections with Wernicke's area to interpret the thing. To interpret the thing. I'm repeating, if I'm saying something to you, your auditory is activating and it is taking that word. And as this auditory area has huge white matter connections with Wernicke's area, that's why Wernicke area is able to interpret that thing. Same like this auditory area, there is a visual area. Whenever you are seeing something, your brain interpret this thing by how? By your Wernicke area. So visual area also has some huge connection with your Wernicke's area. Visual area also have some connection with your Wernicke's area. So for understanding word by seeing or listening, by seeing or listening, and by seeing it is your auditory area, and by listening it is by your sorry, by seeing it is by your visual area. It is by your visual area, and by listening it is by your auditory area. Okay, so your Wernicke area, which is a center in your brain of language, which helps in you understanding the things. क्या देखा है और किसने क्या बोला है, तो उसको अंडरस्टैंड करने में कौन हेल्प कर रहा है हमें? वर्निक्स एरिया। सी, वी हैव सीन दिस डायग्राम ऑफ वर्निक्स। ओके, सो सी दिस डायग्राम, देयर इज योर, here is your वर्निक्स एरिया, here is your वर्निक्स एरिया, ठीक है? here is your primary auditory cortex, this is your primary auditory cortex, and this is your primary visual cortex, this is your primary visual cortex. Both of these, primary auditory as well as primary visual, see this line, the primary visual as well as the primary auditory, they have connection to Wernicke's area such that you can understand the things by listening as well as by seeing as well as. So your visual and your auditory cortex has huge connections with your Wernicke's area such that you can understand what is saying or understand what do you see. Okay, now see this diagram again. This is your visual cortex. This is your auditory area. Done, sir. See, your visual cortex has a connection to Wernicke's area. Your auditory area also has connection with Wernicke's area. Okay, everyone, got this? Everyone has got this concept. Everyone has got this concept. Okay, now see, there another area in your brain is your Broca area. Now, what does the Broca area do? What this your Broca area helps to you? It helps in, it helps in speaking. It helps in speaking or for fluency or motor output, or you can say motor. Okay, Samson, or motor output. So by listening or by seeing, I am understanding through thing with the help of Wernicke's area. Done. This Wernicke's area has connection with Broca area with the help of this arcuate fasciculus. Done. And Broca area, because Broca area is all meant for your speaking purpose. So for speaking, this Broca area has connection with your motor cortex, because your motor cortex has the cortex spinal tract and it will give signal to cortex spinal tract to speak something. So that's why your Broca area has huge connections with your primary motor cortex. So by seeing and listening, I'm by seeing or listening, this information is going to Wernicke's area, and Wernicke's area is interpreting that information. When it is interpreting that information, it passes this information to Broca area with the help of a white matter known as your arcuate fasciculus. And your Broca area is all about your motor speaking part. So this Broca area, because it has to speak, it has connection with the primary motor cortex, and your primary motor cortex has your cortex spinal tract, and cortex spinal tract will go, and you will be able to speak. Okay, everyone. So see this diagram again. This is your Wernicke's area, and this is your Broca's area, and they have connection with the help of this is your arcuate fasciculus. And when this information goes to Broca area and Broca area want to speak, what it will do? It has connection with primary motor cortex. क्या बेटा, इसके पास क्या है? मोटर कॉर्टेक्स से क्या है? कनेक्शंस है, इसके पास कनेक्शन है, और जिसके पास कनेक्शन है वो क्या है? वो सक्सेसफुल है। वो क्या है? सक्सेसफुल। सो ब्रोका के पास किसके कनेक्शन है? मोटर कॉर्टेक्स के। वो क्या करेगा? भाई चलो बोलना तुम चालू करो। ठीक है, नाउ नाउ वी विल ड्रॉ अ डायग्राम एंड अंडरस्टैंड दिस कंसेप्ट अगेन। सी, नाउ now everyone please draw this diagram with me. Okay, see, this is your Wernicke's area. क्या है ये? वर्निक्स एरिया। और ये क्या है? ये है ब्रोका। ठीक है। और इन दोनों को जो आपस में जो कनेक्ट कर रहा है, ये क्या है? ये है मेरा आर्कुएट फेसिकुलस। ये क्या है मेरा? आर्कुएट फेसिकुलस। डन सर। नाउ, अब वर्निक्स एरिया हेल्प्स यू अंडरस्टैंड, बट इट नीड्स ना इंफॉर्मेशन कि अंडरस्टैंड किसको करना है। भाई वर्निंग एरिया अंडरस्टैंड का काम करता है, बट कोई तो बताएगा ना वर्निंग एरिया को कि अंडरस्टैंड क्या करना है, वरना वर्निंग एरिया तो खाली बैठा रहेगा। तो कोई ऐसी चीज तो चाहिए हमें अपनी बॉडी में जो वर्निंग एरिया को बताए कि भाई तेरे को ये अंडरस्टैंड करना है। कोई तो बताए तेरे को पढ़ना क्या, अंडरस्टैंड क्या करना है। सो इसके लिए क्या होगा? इसके लिए मेरे पास है कुछ अलग एरियाज, जैसे कि ये आपका विजुअल विजुअल एरिया। ठीक है। और ये क्या आपका? ये आपका है ऑडिटरी एरिया। ये आपका ऑडिटरी एरिया। और अब खास बात क्या है, इसके कनेक्शन किसके पास है? वर्निक्स के साथ। और इसके कनेक्शन किसके पास है? ऑडिटरी के भी। तो ऑडिटरी और विजुअल दोनों के कनेक्शन किसके पास है? किसके पास जाते हैं उनके कनेक्शन? वर्निक्स के पास जाते हैं। अब वर्निक्स ये इन्फॉर्मेशन किसको देता है? ब्रोकास को देता है। वर्निक्स इज गिविंग इट इन्फॉर्मेशन टू ब्रोकास विद द हेल्प ऑफ आर्कुएट वेसिकुलस। नाउ ब्रोका इज द मोटर आउटपुट, so it wants to speak something, and for speaking you need some connection with the primary motor cortex. So if this is your central sulcus, suppose it is a central sulcus, this will be your motor cortex area. This will be your motor cortex area. And your Broca, it has connections with motor cortex. And one more thing interesting, this Broca also has connection with basal ganglia. Why? Because basal ganglia to help in tuning, to help in tuning of the movement, to help in tuning of the movement. This Broca also have connection with thalamus, such that the a motor output should be done in a coordinated manner. It should be done in a coordinated manner. So Broca के motor cortex से भी connection है, basal ganglia से भी, thalamus से, such that there should be a fine tuning, such that there should be a fine tuning. Okay, everyone. किसी को कोई doubt है, just tell me in comment section. I will repeat again. If anyone having any doubt till now here, just tell me in comment section. Anyone till now any doubt? किसी को यहाँ तक कोई डाउट? जस्ट टेल मी इन कमेंट सेक्शन. ओके जैजिल, ठीक है। सब बताओ फटाफट, ब्रोका एरिया का ब्रॉडमैन नंबर क्या है? ब्रोकाज एरिया का ब्रॉडमैन नंबर क्या है? फटाफट बताओ कमेंट सेक्शन में कि ब्रोकाज एरिया का ब्रॉडमैन नंबर क्या है। एनीवन? ब्रोकाज एरिया का ब्रॉडमैन नंबर क्या है? बी फॉर ब्रोका। ब्रोका कहाँ पे है? फ्रंटल लोब में। F44, F44। वर्निस एरिया कहाँ है? टेम्पोरल लोब में। TT22। ओके एवरीवन। और विजुअल एरिया का नंबर क्या है? विजुअल एरिया का ब्रॉडबैंड नंबर क्या है? 17। विजुअल एरिया का ब्रॉडबैंड नंबर क्या है? 17। विजुअल माने सी। विजुअल मतलब क्या है? टू सी समथिंग। एंड सी सी 17। सी सी 17। सी सी इज योर 17। डन एवरीवन। याद रखिए ब्रॉडबैंड नंबर 44 22 17। चले आगे। चलो नाउ, सो सी, वी आर हेयरिंग वर्ड और वी आर सीइंग द वर्ड बाय रीडिंग। बाय रीडिंग वी आर सीइंग द वर्ड। ठीक है। अगर वी आर सीइंग समथिंग, तो इट विल बी प्रोसेस्ड बाय योर विजुअल कॉर्टेक्स। एंड इफ वी आर हियरिंग समथिंग, इट विल बी प्रोसेस्ड बाय योर ऑडिटरी कॉर्टेक्स। यहां से सब इंफॉर्मेशन कहाँ जाएगी? ऑल इंफॉर्मेशन विल गो टू योर वर्निक्स एरिया। इट विल गो टू योर वर्निक्स एरिया। एंड विद द हेल्प ऑफ योर आर्कुएट fasciculus, with the help of your arcuate fasciculus, this information will go to Broca area. This information will go to Broca area. And Broca area के पास क्या है? Cerebellum, thalamus, basal ganglia से कनेक्शन है, जिससे देयर कैन बी अ फाइन ट्यूनिंग ऑफ द मूवमेंट्स। एंड ये कहाँ जाके रिले करेगा? मोटर कॉर्टेक्स में। और फिर कहाँ जाएगा? फिर हम वर्ड्स को बोल देंगे। फिर हम वर्ड्स को क्या करेंगे? बोल देंगे। सी, सो everyone is seeing this diagram. So see, this diagram is all about seeing. It is about seeing of language, of seeing of language. क्या हो रहा है भाई? जो मेरा विजुअल एरिया है, जो मेरा विजुअल एरिया है वो एक्टिवेट हो रहा है क्योंकि मैं सब कुछ देख रहा हूं। अगर मैं कुछ देख रहा हूँ, इन्फॉर्मेशन कहाँ जा रही है? वर्निक्स एरिया में जा रही है। कहाँ जा रही है वो? वर्निक्स एरिया पे जा रही है। और वर्निक्स एरिया से वो इन्फॉर्मेशन आर्कुस फैस्कुलस पे तो कहाँ जा रही है? ब्रोका पे जा रही है। कहाँ जा रही है ये? ब्रोका पे जा रही है। और ब्रोका से कहाँ जा रही है? ये गई आपकी ब्रोका पे। ये आ गया वर्निक्स। और ये आ गया आपका विजुअल एरिया। और ब्रोका से कहाँ जा रही है? ये जा रही है प्राइमरी मोटर कॉर्टेक्स में। और प्राइमरी मोटर कॉर्टेक्स से कॉर्टिको स्पाइनल ट्रैक्ट, कॉर्टिको बल्बार ट्रैक्ट आते हैं। और उसके थ्रू ब्रेन स्टेम से मसल ऑफ लैरिंग्स पे, क्योंकि लैरिंग्स हेल्प इन साउंड प्रोडक्शन। लैरिंग्स हेल्प इन योर साउंड प्रोडक्शन। सी अनदर डायग्राम। दिस इज योर लिसनिंग। दिस इज योर लिसनिंग ऑफ लैंग्वेज। दिस इज योर लिसनिंग ऑफ लैंग्वेज। अब यहाँ पे क्या हो रहा है भाई? प्राइमरी ऑडिटरी एरिया क्या हो गया? एक्टिवेट हो गया। ये कहाँ जा रही है इन्फॉर्मेशन इसकी? वर्निक्स पे। और वर्निक्स कहाँ जाएगा? अपने भाई ब्रोका के पास। और ब्रोका को क्या करना है? मोटर। तो ब्रोका खुद तो पढ़ नहीं सकता, तो ब्रोका को क्या चाहिए? कुछ कनेक्शन। और ये कनेक्शन क्या है? मोटर कॉर्टेक्स के। क्या है कनेक्शन ये? मोटर कॉर्टेक्स के। ठीक है। अब मोटर कॉर्टेक्स कैसे बुलाएगा? या तो कॉर्टिको स्पाइनल ट्रैक्ट के थ्रू, या कॉर्टिको बल्बार ट्रैक्ट के थ्रू। और ये कहाँ पे जाएगा? मसल्स ऑफ लैरिंग्स पे। क्यों लैरिंग्स पे? क्यों? बिकॉज लैरिंग्स इज अ साउंड बॉक्स। लैरिंग्स इज अ साउंड बॉक्स। वी हैव स्टडीड इन 12th क्लास कि भाई लैरिंग्स क्या है? लैरिंग्स है मेरा साउंड बॉक्स। ये तो मैंने पढ़ा है 12th क्लास में। तो कॉर्टिको बल्बार ट्रैक्ट ब्रेन स्टेम की न्यूक्लियाई, जो कॉर्टिको बल्बार ट्रैक्ट, जो कॉर्टिसोनल ट्रैक्ट में जाएगा। क्यों? क्योंकि जो ब्रेन स्टेम में न्यूक्लियाई है, स्पेशली योर 9, 10, 11, 12, दीज आर योर बल्बार नर्व। दीज कंट्रोल योर साउंड पार्ट। Your cortical bulbar tract will go to this nuclei and you will be able to speak. You will be able to speak. Okay, everyone. तो ऑडिटरी से गया वर्निक्स पे, वर्निक्स से गया ब्रोका पे, ब्रोका से गया मोटर पे। तो हो जाए। तो ऑडिटरी से गया वर्निक्स पे, वर्निक्स से गया ब्रोका पे, किसके थ्रू? आर्कोफैस्कुलस के थ्रू। ब्रोका से गया मोटर कॉर्टेक्स पे। और मोटर कॉर्टेक्स से कहाँ गया? कॉर्टिको बल्बार ट्रैक्ट। कॉर्टिको बल्बार ट्रैक्ट। ये तो कहाँ गया? ब्रेन स्टेम। या गुड इवनिंग पुनीत, हाउ आर यू? कहाँ गया? ब्रेन स्टेम के क्रेनियम न्यूक्लियाई के पास। ब्रेन स्टेम के क्रेनियम न्यूक्लियाई के पास। और इनको क्या बोलते हैं? बल्बार नर्व्स। इनको क्या बोलते हैं? जो हमारा लास्ट लेक्चर था, आर लास्ट लेक्चर विच वाज अबाउट सूडो बल्बार एंड बल्बार पासी, दे क्लियर कट स्टडी व्हाट आर बल्बार नर्व्स। तो कहाँ गया? बल्बार नर्व्स पे। वहां से कहाँ पे गया ये? फेरिंग्स, लैरिंग्स। या पुनीत, आई एम फाइन। सो फेरिंग्स, लैरिंग्स पे, एंड देन योर tongue part, then your tongue, and you will be then able to speak. You will be then able to speak. Anyone till now? Any doubt? Anyone till now? Any doubt? So see, now, now your Broca area, now your Broca area will give command to you to speak. But for speaking, you need sounds also, and you need articulation power also. So how does it will happen? See, there is something known as your phonation. There is something known as your phonation. क्या? Phonation. It is production of, it is production of, yeah, Puneet, right. It is production of sound. And how sound is produced? It is produced with the help of lungs and vocal cords. Because when you are expiring, when you are doing expiration, when you are doing expiration, sound will be coming. Sound will be coming to larynx. Sound will be coming to sound will be coming to larynx. Done. And it will be hitting. It will be hitting your vocal cords, because at the time of sound production, vocal cords are closed. At the time of sound production, vocal cords are closed. They are open at the time of respiration. At the time of sound production, they are closed. So when the expiration air will hit the closed vocal cord, there will be production of sound. There will be a production of sound. Then other is your articulation. Other is your articulation. Now you have produced the sound. Sound is also produced by babies, but babies are not able to convert their sounds into words. You are able to convert the sound into words. Why? Because you are able to manipulate your tongue, soft palate, lips, lungs in the way such that sound can be converted into words. So by facial muscles, yeah, yeah, very good, Puneet. By facial muscles like your tongue, your palate, your lip, your pharynx, you should be able to convert convert the sound. You should be able to convert the sound in a meaningful word. In a meaningful word. ओके, वी शुड बी एबल टू कन्वर्ट द साउंड इन मीनिंगफुल वर्ड. क्योंकि साउंड तो बच्चा भी प्रोड्यूस कर रहा है, बट क्या वो वर्ड्स बोल पा रहा है? नहीं, बच्चा वर्ड नहीं बोल पा रहा. क्यों? क्योंकि उसके कॉर्टिको बल्बर ट्रैक्ट और कॉर्टिकस ट्रैक्ट डेवलप ही नहीं हुए बच्चे के. जो बच्चा 1 साल का है, क्या उसके ट्रैक्ट डेवलप है? नो, ट्रैक्ट आर नॉट डेवलप. बट हमारे कॉर्टिको बल्बर और कॉर्टिकस ट्रैक्ट डेवलप्ड है. तो मेरी जो साउंड आ रही है, बट आई एम एबल टू गिव प्रोड्यूस इट इन अ वर्ड. व्हाई? Because I am able to manipulate my tongue, lips in such a beautiful manner that words are producing. Yeah, Samson, I will repeat again. Don't worry. ठीक है? And all this, your tongue, palate, lips are controlled by your cranial nerve nuclei, like your 9th, 10th, 11th, and 12th nerves. So, Samson, what I was telling, that your Broca areas have given some commands to your primary motor cortex. Now, if primary motor cortex wants to produce sound, it has to act, and it has to act through corticobulbar tracts or corticospinal tracts. And your corticobulbar tract, corticospinal tract controls something, will be controlling something which will be producing sound. In our body, there are two or three structures which help us to produce sound. First, when it comes to production of sound, that is your phonation part. It is done by your lungs and vocal cord. When I'm doing expiration, not in inspiration, sounds are always produced in expiration. So when I'm doing expiration, when I'm exhaling, the air which is coming out are hitting my closed vocal cord. Air which is coming out, it is hitting my vocal cord. So suppose these are my vocal cords and these are closed, and below this air is coming, so my vocal cords will vibrate. There will be vibration in vocal cords. So there will be production of sound. Okay, there is production of sound. Now sound is produced by 1 year boy also, but he is not able to convert it into words. Why? Because in a boy of 1 year, your corticobulbar tract and corticospinal tracts are not developed that much. But in me, my corticobulbar and corticospinal tract both are developed. So by manipulating my tongues, my palate, my lips, I am able to produce beautiful words. I am beautiful. I am able to produce beautiful words because I am able to articulate. I am able to articulate that sound in a beautiful words. Okay, just like a flute. Suppose this is a flute, and if I am blowing air, only a sound will come. But if I am playing the flute in a beautiful manner like this, a beautiful sound will come. Okay, just like tomorrow there is Janmashtami, na? Like Krishna, there is a Basuri. So when you are playing a Basuri and you are whistling it, only a sound will come. But when you will play it in a beautiful manner with the help of your beautiful finger, a proper music, a melody sound, a melody word will be coming. Okay? No, then there is no role of Wernicke. Okay, everyone, got this? If this is my Basuri, this is my flute. If I am blowing somewhere, there will be sound. But if I am articulating with the help of my finger, a beautiful words will come. Okay, everyone? Now see, if this is your brainstem, ठीक है बेटा? This is your midbrain. This is your pons. This is medulla. And here is a structure that is your cerebellum. क्या है ये? Cerebellum. अब इनको कौन कंट्रोल करेगा? आपका मोटर कॉर्टेक्स. ये क्या है आपका? मोटर कॉर्टेक्स. और यहां से क्या आ रहे होंगे? कॉर्टिको बल्बर फाइबर जो पेलिनस को कंट्रोल करते हैं, और आपके कॉर्टिको स्पाइनल ट्रैक्ट जो मसल्स वगैरह कंट्रोल करते हैं. अब साउंड कहां से आती है? साउंड आती है आपके लैरिंग्स से. तो समझ लो ये आपका है लैरिंग्स. ठीक है, ये आपका लैरिंग्स. क्या है ये? लैरिंग्स. ठीक है, ये आपके, ये आपकी हो गई लिप्स. ये आपकी हो गई टंग. ये आपका हो गया पैलेट, सॉफ्ट पैलेट. ठीक है, एंड ये हो गया आपका पैरिंग्स. ये होगा आपका पैरिंग्स. डन. ठीक है, अब मेडुला से कौन कौन सी नर्व आ रही है? आपकी नाइन्थ, आपकी टेंथ, आपकी इलेवेंथ, और आपकी ट्वेल्थ. ठीक है, ये ट्वेल्थ नर्व कहां जा रही है? ये ट्वेल्थ नर्व इज गोइंग टू टंग. डन सर. योर नाइन्थ नर्व इज गोइंग टू pharynx. Your 10th and 11th, these nerve are going to pharynx, as well as 10th nerve is coming to larynx. So 10th nerve have dual function. It helps in phonation as well as in articulation. ठीक है, and your lips are supplied by the seventh nerve. Done. So your bulbar nerves, that is your 9, 10, 11, and 12. They are controlling the muscles of sounds. They are controlling the muscles of sound. They are controlling this neuromuscular apparatus of, they are controlling the neuromuscular apparatus of sound. ठीक है, अब Broca's area ने, when Broca area have given signal to primary motor cortex to produce sound, it will tell the corticobulbar tract. So corticobulbar tract is coming. See, your corticobulbar tract are coming, and they are controlling this nerve. This is your corticobulbar tract, CBT. Your CBT stands for corticobulbar tract. Okay, for controlling this cranial nerve. Done. And these nerves, these cranial nerves and this corticobulbar tract, they also have connections with cerebellum. Why? Because to produce a sound in a well tuning manner, it has connection with the cerebellum also. So your sound is produced by bulbar nerve. Bulbar nerves are themselves produce sound, and they are also controlled by CBT, because your bulbar nerves produce sound. But who will tell them what sound to produce, how to produce, and how to manipulate them? Some higher center will be there. So your corticobulbar tracts manipulates your bulbar nerves in a beautiful way, such that suppose in my mind there is a program coming to say a word red, to say a word red. So this program of primary motor cortex to say a word red will be sent into corticobulbar tract. कि corticobulbar tract 9, 10th, 11th, 12th नर्व को इस वे में मैनिपुलेट करो. क्या 9, 10th, 11th, 12th नर्व को मैनिपुलेट करो in a such a way that a word should be coming that is red. So red. Okay, everyone, got this concept? Just give me a thumbs up if you have understood the whole mechanism of phonation and articulation. Sharma, Puneet, any Dheeraj, just give me a thumbs up. That very good. So now see this diagram. This is your this is your speech area and voice area motor cortex. From here corticobulbar tract are coming. क्या आ रहा है? Corticobulbar tract आ रहा है. और कहाँ जा रहा है corticobulbar tract? It is going in medulla. And see here, this tenth nerve is manipulating the tenth nerve, and tenth nerve is going to larynx. Tenth nerve कहाँ जा रही है? Recurrent larynx में. And sound will be coming. Sound will be coming. And other nerves also will be manipulating in such a way only. So see this diagram. The lungs serves as a reservoir for air. Lungs क्या है? Air के reservoir है. And in speaking, air is forced from the lungs. क्या? Air is forced from the lungs to the larynx into the three main cavities: pharynx, nasal, and oral cavity. Air can be inhaled and exhaled without much sound. To produce speech sound, the flow of air is interpreted by the vocal cords. क्या? To produce a sound, and that also in expiration phase. That also in expiration phase. So in expiration phase, sound is coming and it is manipulating by your vocal cords. See this diagram, this airflow. You are seeing this airflow. Yeah, sir, we are seeing this airflow. Sound is coming from trachea, it is going to larynx. And these are your vocal cords. That is your vocal cord. It is closing such that the airflow will strike this vocal cord and it will lead to generation of some sounds. It will lead to generation of some sounds. So this is your air pressure system. This is your phonatory system. That is your larynx. Because with the help of vocal cords and air striking it, air striking it, a sound will come. And your articulatory system, that is your pharynx, oral and nasal cavity, will lead to production of a beautiful words, a melody song. See again a diagram. These are your lungs, which are full of air. A force of expiration will come. So air will be going. It will be hitting your vocal cord. Vocal cords will be hitting, and the sound will be going to your pharyngeal cavity, your oral cavity, nasal cavity, and your soft palate, and they will articulate in a beautiful manner, such that a sound will come. Such that a sound will come. Okay, everyone. So see this diagram. In respiration, vocal cords are open, but in phonation, at the time of sound production, क्या हो रहा है vocal cords का? क्या हो रहा है भाई vocal cords का बताओ? वोकल कॉर्ड सर बंद हो रहे हैं, क्योंकि जब एयर आएगी स्ट्राइक करेगी, खुले वोकल कॉर्ड पे स्ट्राइक करेगी नहीं वो, बंद पे तो स्ट्राइक करके तो आवाज निकलेगी. तो वोकल कॉर्ड्स क्या हो रहे हैं? बंद. एंड नाउ व्हेन साउंड इज प्रोड्यूस्ड, व्हेन साउंड इज प्रोड्यूस्ड, when sound is produced, it is being manipulated by your lips, tongue, in a beautiful manner, such that a beautiful words are coming out. Such that a beautiful words are coming out. Okay, Sharma Puneet, any doubt till now here? Just tell me. Have you gone explain the, have you been able to understand the whole mechanism of sound production? See, I will repeat again. My brainstem nuclei 9, 10, 11, 12. They control the tongue, all this part, pharynx, larynx, which helps in articulation. And 10th nerve also control larynx, which helps in production of sound. ठीक है? Sound किससे प्रोड्यूस होती है? मैं when I will expire, yeah, when I will expire, this expired air will be coming out from my system, and when it will be coming out from my system, it will hit vocal cord. A vocal cord, when it will be hitting, my vocal cords will be vibrating like tabla. They will be vibrating like tabla, tak dhun, and there will be a sound will be coming. A sound will be coming, and with the help of my beautiful lips, my tongue, my soft palate, it will be converting into a beautiful words. Like, just like I am playing a flute, and if I am blowing air, only sound will come. But if I play a flute in a beautiful manner, if I articulate with my beautiful finger, the sound will be converted into a melody song. The sound will be converted into a melody song. Okay, बच्चों, कोई डाउट किसी को? चले आगे, सबको समझ में आ गया? हाँ, सारे गा या शर्मा प्लीज, सारे गा मापा। ठीक है, अब हम समझेंगे कि ओके शर्मा प्लीज। नाउ नाउ देयर कैन बी टू थिंग्स. One is your one is your dysphonia. One is your dysphonia. अब dysphonia कब होगा? Either your 10th nerve is gone, और साउंड कौन प्रोड्यूस करता है? Either there is some respiratory issue, then dysphonia will be there. Now we'll come to कि भाई dysarthria कब होगा? When there will be dysarthria. तो सबसे ऊपर से स्टार्ट करते हैं. We will start from above. So this is my system. सबसे पहले, अगर मेरा जो सीबीटी है, दैट्स माय कॉर्टिकल ट्रैक्ट इज देयर, इफ इट विल बी डैमेज, if my cortical tract is damaged, then I will be able to produce sounds. I will be able to produce words also. But will I be able to produce a beautiful words? No, because controlling from cerebral cortex has gone. So there will be some kind of dysarthria. So first is damage to your cortical tract. Then if there is damage to your bulbar nerves, then also sound will be not be there. Articulation will be gone. So if there is damage to your bulbar nerves, other, if your tongue, lips, if your tongue, lips, soft palate is damaged, suppose, so if there damage to these muscles, then also articulation will not be there. Suppose if there is damage to cerebellum, then also articulation will be gone, because your cortic bulbar tract, all this system are continuous in touch with cerebellum, such that there should be a fine tuning. And if there is not a fine tuning, then also there will be kind of a dysarthria. ठीक है? अब क्या होगा? And these nerves which are going here, they are ending in a neuromuscular junction. They are ending into muscle in the way of NMJ junction. So if there is damage to some NMJ junction, then also sound will not be there. And if there is some myopathy, if the tongue muscle is gone due to myopathy, then also dysarthria will be there. Then also dysarthria will be there. So we will start with one by one. That is your UMN fibers damage. That is, in last class we have studied. That is, if there is pseudobulbar palsy. Please, if you want to know what is the difference between pseudobulbar palsy and bulbar palsy, and in pseudobulbar palsy there is spastic dysarthria, and bulbar palsy there is a flaccid dysarthria. I've told that in my last lecture. You can see that there will be pseudobulbar palsy. Okay, and if there is suppose extrapyramidal system damage, especially in Parkinson, so it will be also result in UMN fiber. Okay, other is your cranial nerve nuclei. That is your bulbar palsy. That is your bulbar palsy. Third, if there is something in your affecting your cerebellum, if something there is affecting your cerebellum. Fourth, if there is something that is affecting your neuromuscular junction. Can anyone tell me which all these? Like your myasthenia gravis. Okay. Other is your myopathy. And muscles of respiration is affected. Muscles of respiration. Muscles of respiration affected. Like in your Guillain-Barré syndrome. In Guillain-Barré syndrome, we all know that there is something known as neuromuscular paralysis. Then also sound will not come. Then also sound will not come. Okay, everyone? Everyone till now, okay? Shall we move forward? Now, we will see the different kinds of dysarthria. So, see, there is a flaccid dysarthria, there is a spastic dysarthria. Spastic is when there is pseudobulbar palsy, and flaccid is when there is bulbar palsy. How to distinguish between bulbar palsy? If there is a bulbar palsy, your LMN are gone. So tongue में क्या होगा? Fasciculation, and there will be affected to special kind of dysarthria. facial अगर facial paralysis है, तो then BPM will gone. If only tongue is affected, then DNSTX will gone. But in spastic, your tongue will be small and spastic, and you will be find it very difficult to speak. You will find very difficult to speak. Okay. Then comes if you are having a cerebellar disorder. Cerebellar में क्या होता है? Whenever there is cerebellar disorder, there is ataxia. क्या होता है तब? Ataxia. तो इसमें कैसी स्पीच होती है? या तो स्कैनिंग होगी या स्टेकेटो स्पीच. तो स्कैनिंग स्पीच कैसे? इफ सपोज आई वांट टू नेम अ वर्ड दैट इज शाहरुख खान. शाहरुख खान आई वांट टू से. इन स्कैनिंग स्पीच आई विल से शाहरुख खान. Understanding? If I am having a cerebellar disorder and there is scanning kind of speech, so I will say Shah Rukh Khan. I will be scan forward. And what do you understand by staccato speech? There is explosiveness. So I will be saying like Shah Rukh. I will say Shah Rukh. So I am exploding at an area where I don't should be explosive one. I am saying I am saying some alphabets in that word very much loudly. But I don't. But there is no something required to be loud. There is no such thing that I should be loud in that word. Sorry, I should be loud in that alphabet, but I am still loud at that alphabet. So that is some explosive speech. Suppose I want to say pencil, I will say pencil, and I want to say some. I want to say a word like I want to go there. I will say like I want to go there. So I am without any reason. I am saying that word very much loudly. But does I require to say that word very much loudly? No. So it is a kind of a staccato speech. So either it can be scanning speech in cerebral disorder or it can be a staccato speech in which a patient is explosive where he should not be explosive. He is explosive in few words where he should not be explosive. So scanning, suppose I have to say Shah Rukh Khan, I will say Shah Rukh Khan. I will scan whole the word. Staccato, Shah Rukh. So I am being explosive at the end, but I shouldn't be explosive. But still, I'm getting being explosive. Why? Because there is a cerebellar disorder. Then comes your extrapyramidal disorder and Parkinson. अब Parkinson में क्या होगा? Initially, patient will start to speak. We all know that Parkinson patient, in Parkinsonism patient, there is hypokinesia. ठीक है? So I will start speak, but when I will progress, my volume will decrease. I will start with normal volume, and within some time, within a period of time, my volume will decrease. My volume will decrease. This is Parkinson type of stuff. Okay, beta. Next come your hyperkinetic dysarthria like chorea, acetosine dyskinesia. अब hyperkinetic dysarthria में क्या हो रहा है? Suppose if there is hyperkinetic disorder, there will be tremors of my tongue. There will be tremors of my tongue. So if I am speaking some word, I am speaking, suppose I am speaking pencil. So if I am speaking pencil and suddenly a tremor will come, my I will be suddenly stopping. I will be suddenly stopping. So there is a sudden stopping. One thing, there is a sudden stopping. And if there is tremor in tongue, so the vowels which we pronounce with tongue, like ta dha na, like ta dha na, they will be affected. They will be affected. So there it will be called as a lingual dysarthria. There will be a lingual dysarthria. There will be a lingual dysarthria. So in hyperkinetic one, sudden stoppage, sudden stoppage. Other, there will be a lingual dysarthria. Vowels affecting tongue. Vowels affecting tongue will be gone. Next is your myasthenia gravis patient. We all know that myasthenia gravis is a neuromuscular junction disorder. So now we all know as the day passes, the weakness of myasthenia gravis patient increases. The weakness of myasthenia gravis patient increases. So suppose I am a patient of myasthenia gravis. I am a patient of myasthenia gravis. So I will be speaking. I will be speaking. But as the day progress, as the day progress, there will be fatigueness. There will be fatigueness. My palate muscles will get fatigue. My palate muscles will get fatigue. And it is in a type of a bulbar palsy. Myasthenia gravis patient, it is a type of bulbar palsy because NMJ junction is affected. And NMJ comes in your element part. NMJ is a part of lower motor neuron part. So there will be then a flaccid dysarthria. A flaccid dysarthria, which will be presented to as a hypernasality. Hypernasality. So morning में sound कैसे आएगी? I have to say, suppose there is 8 a.m. I will say pen, but if I have to say that same word in my night, I will pen, I will say pen, I will say pen, because when I am speaking again and again, I am getting fatigued, and especially fatigueness increases in evening because I am doing whole activities from all day. So evening fatigueness increases. So at the time when I will come to evening, there will be some hypernasality component in my voice. ओके एवरीवन, किसी को यहां तक कोई भी डाउट इन चारों डिसऑर्थोग्राम में, फ्लैसिड, स्पास्टिक, अटैक्सिक, हाइपोकिनेटिक, हाइपरकिनेटिक और माइस्थीनिया ग्रेविस? जस्ट टेल मी इन कमेंट सेक्शन. इफ यू वांट आई शुड रिपीट, आई विल आल्सो रिपीट अगेन. एनीवन? इज एवरीवन ओके टिल नाउ हियर? जस्ट टेल मी इन कमेंट सेक्शन. सबको टाइप्स ऑफ डिसऑर्थोग्राम समझ में आ गए? एवरीवन? सैमसन, पुनीत, धीरज, एवरीवन ओके टिल नाउ? एवरीवन? जस्ट गिव मी thumbs up if you have understood till now. Sharma, Puneet, shall we move forward then? So I will be repeating again. There are five kinds of disorder: flaccid, spastic. Spastic, flaccid. Flaccid is like your bulbar. Spastic is like your human. In flaccid, there will be tongue fasciculation, and particular part of disorder will be affected. Suppose my ninth nerve is affected, so my ninth nerve is supplying to pharynx, it will be affected. So vowels come from tongue, soft palate, and your lips. They will be affected. So lips is supplied by seventh nerve, so only seventh nerve vowels are affected. If suppose my 12th nerve is affected, so only my tongue's vowel will be affected. This is your flaccid dysarthria. It is specific. Then comes the spastic. It is like a pseudobulbar palsy. So tongue will be small and spastic. One, you can't move your tongue. If I am saying to you like that, move your tongue, up and down. But that patient cerebral bypass, spastic patient will be not be able to move his tongue. One. Then comes your ataxic speech. That is in your cerebellum disorder. In this, there are two kinds. There is scanning and staccato. Scanning is like you are scanning the whole world. Like if I have to say Shah Rukh Khan, I will say like Shah Rukh Khan. I will be scanning whole world. Staccato is like I am increasing my amplitude of volume in some parts of words in which normally I shouldn't be increased. Suppose if I have to say that I am going to somewhere, I will be saying like that. I am going to somewhere. So suddenly I'm increasing my sound. But it was not required. That is a scanning speed. Then comes your hypokinetic. It happens in Parkinson. Gradually, when you're trying to speak, your volume will start to decreasing. Then comes your hyperkinetic, which is seen in your chorea dystocia. So in hyperkinetic, there are tremors in tongue. So whenever you are speaking, suddenly you will stop because tongue tremors are there. And as there is tongue tremor, so vowels which are produced by tongue, they will be affected, like ta, da, na. Then comes your myasthenia dysarthria or myasthenia patient gravis. In myasthenia gravis, we all know that as the day progresses, their weakness increases. So same will happen with this patient. As the day will progress, his or her weakness will increase. Okay, so when weakness will increase, so there will be fatigueness, and we all know that myasthenia gravis is a neuromuscular junction problem, and neuromuscular junction come under the lower motor neuron type of problem, and lower motor neuron is a flaccid dysarthria, and flaccid dysarthria have a greater component of hypernasality. We have also did in our last class of pseudobulbar and bulbar palsy. So then what will happen as the day will progress, as there will be fatigueness, it will the normal voice will be converted into a nasal voice. A normal voice will be converted into a nasal voice. So suppose if I want to, if I in morning I am saying pencil, in evening I will say pencil, pencil. So voice will be have a nasal component when there will be a fatigueness of palatal muscle. So okay everyone, shall we move forward then? सबको समझ में आ गया? Anyone till now here any doubt? Then we'll proceed to our new portion, that is aphasia. Anyone till now here any doubt? Samson, Dheeraj. Okay. Now, now we come to aphasia. So what is aphasia? Anyone in comment section can tell me कि aphasia क्या है? Aphasia is a language problem. It is a language problem in which due to some cortex problem, some cortex problem, you are not able to program things properly, not able to program things properly. ठीक है? In the presence of a normal auditory, visual, and many times a normal motor also. That is your normal phonation and normal articulation. Yes, Shakti, you are right. Okay, beta. So, and so this is a diagram. This is your Broca area, and this is your Wernicke's area. This is your Broca and Wernicke's area. So we will start one by one. First, we will come to Wernicke's area. Suppose if there is a patient in which Wernicke's area is damaged, there is a patient in which Wernicke's area is damaged. So just tell me in comment section if there is a patient in which a Wernicke's area is damaged, what all things you will see. There is a patient in which Wernicke's area is damaged, tell me what all things you will see in that patient. If there is a patient in which Wernicke's area is damaged, tell me in comment section what things you will see. Sakshi, Samson, Dheeraj, anyone? Wernicke's area patient में damage है, what will be the manifestation? अफेजिया तो होगा, ये तो हमें पता है यार बेटा। अफेजिया तो होगा ही ना, हम अफेजिया ही पढ़ रहे हैं। डेफनेस क्यों होगी बेटा वर्निक्स एरिया में? वर्निक्स एरिया क्या करता है? डेफनेस क्यों होगी बेटा? ऑडिटरी एरिया थोड़ी ना इफेक्ट है आपका, ऑडिट एरिया थोड़ी ना इफेक्ट है बेटा। वर्निक्स एरिया अलग है ना, ये तो लैंग्वेज का पार्ट है। अफेजिया, ओके यू आर राइट कि अफेजिया होगा बिल्कुल। और दूसरा काम क्या है वर्निक्स एरिया का? वर्निक्स एरिया काम है टू अंडरस्टैंड द थिंग्स, टू बी गुड इन कॉम्प्रिहेंशन। या हर्निकल, वेरी गुड। कॉम्प्रिहेंशन विल बी अफेक्टेड ना। व्हाट इज द फंक्शन ऑफ वर्निक्स एरिया? आई हैव टोल्ड इन माय इन स्टार्टिंग ना ओनली कि भाई अगर हम ये देखिए, कहाँ गया ये रहा। वर्निक्स एरिया हेल्प्स यू इन अंडरस्टैंडिंग फॉर वर्ड्स, it helps in comprehension, and Broca is a help in speaking. So if Wernicke area is affected, your comprehension will be gone. So your comprehension, your comprehension is affected. Okay, done. Wernicke's area is in posterior part, so there will be a, we also say it as a posterior aphasia. But if Wernicke's area is damaged, but your Broca area is normal, so fluency will be normal. So it is also known as fluent aphasia. It is known as fluent aphasia. Okay. When we compare to Broca's area, in Broca's area, your fluency will be affected. So it is a type of a non-fluent aphasia. क्या है ब्रोका? Non-fluent aphasia. Then Broca area कहाँ पे है? It is in anterior part. So it is also known as anterior aphasia. It is also known as anterior aphasia. It is also known as mute aphasia because you are not able to speak anything. But as your Wernicke's area is intact, as your Wernicke's area intact, you will be able to, you will be able to understand the things. You will be able to understand the things, but you will be not be able to say the things. You will be able to understand the things, but you will be not be able to see say the things. तो वर्निक्स में क्या गया? मेरा कॉम्प्रिहेंशन गया, मेरे को समझ नहीं आएगा। वर्निक्स गया तो समझ नहीं आएगा, बट ब्रोका गया तो मैं बोल नहीं पाऊंगा। तो वर्निक्स में बोल पा रहा हूं, इसलिए फ्लुएंट अफिजिया, आई एम एबल टू स्पीक। बट इन ब्रोका आई एम नॉट एबल टू स्पीक, दैट्स व्हाई इट इज नोन एज नॉन फ्लुएंट टाइप ऑफ अफिजिया। Okay, everyone? Everyone till now okay? And Broca area is in anterior part, that's why anterior aphasia. Wernicke's area कहाँ है? Posterior part, that's why it is your posterior aphasia. Other thing, then is your arcuate fasciculus. ये क्या करता है? Arcuate fasciculus is connecting both your Wernicke's and Broca's area. So if it is damaged, if it is damaged, then what will happen? It is known as your conductive aphasia. Conductive aphasia. That's why repetition is affected. क्या इफेक्ट होता है? Repetition is affected. You will be not be able to repeat the things. You will be not be able to repeat the things. तो वर्निक्स गया तो समझ नहीं आएगा, ब्रोका गया तो बोल नहीं पाऊंगा, और अगर आर्कुएट फैसिकुलस गया तो रिपीट नहीं कर पाऊंगा। तो मेरे साथ वर्निक्स समझ नहीं पाऊंगा, ब्रोका बोल नहीं पाऊंगा, आर्कुएट रिपीट नहीं कर पाऊंगा। वर्निक्स समझ नहीं पाऊंगा, ब्रोका बोल नहीं पाऊंगा, आर्कुएट रिपीट नहीं कर पाऊंगा। वर्निक समझ नहीं पाऊंगा, ब्रोका बोल नहीं पाऊंगा, आर्कुएट रिपीट नहीं कर पाऊंगा। ओके एवरीवन, गॉट दिस? ठीक है. So we will start. It is in a language issue. So lesion will be always in dominant hemisphere. लीजन कहाँ पे होगा? डोमिनेंट हेमिस्फेयर में होगा. ओके सर, डन. लीजन कहाँ होगा? डोमिनेंट हेमिस्फेयर में होगा. ठीक है. मैक्सिमम टाइम डोमिनेंट हेमिस्फेयर इज योर मोस्ट कॉमन लीजियो योर लेफ्ट साइड. इट इज योर लेफ्ट विंग एंड starts with Broca. When Broca is gone, when Broca is gone, with Broca, with it, some arcuate, arcuate fasciculus is also affected. With it, some arcuate fasciculus is also affected. ओके. सो क्या होगा? ब्रोका एरिया में क्या होगा? वन, इट इज अ नॉन फ्लुएंट अफेजिया. इट इज अ नॉन फ्लुएंट अफेजिया. Other thing, whenever there is a damage to Broca's area, when I am saying it is in a Broca's aphasia, when I am saying it is in a Broca aphasia, when I am saying it is in a Broca aphasia, with Broca's area, some part of outward facility is always damaged. That's why when it is Broca aphasia, you will get a non-fluent aphasia plus your repetition. Your repetition will be also impaired. Your repetition will be also impaired. Next is your next is your Wernicke's. Next is your वर्निक अफेजिया. अब वर्निक अफेजिया में क्या इफेक्ट होगा आपका? वर्निक्स एरिया. आपका वर्निक्स एरिया. ठीक है. ये देखो, ये मेरा है ब्रेन एंड ये है वर्निक्स, ये है ब्रोका. एंड व्हाट इज दिस? दिस इज द आर्क्वेट फेसिकुलस. सो इन ब्रोका एरिया क्या क्या गया? मेरा ब्रोका गया एंड सम पार्ट ऑफ आर्क्वेट फेसिकुलस गया. ओके. नाउ इन वर्निक्स एरिया, your वर्निक area will be gone and some part of arcuate fasciculus, some part of arcuate fasciculus is also affected. That's why it is in a fluent aphasia. It is in a fluent aphasia, and in this also repetition. In this also, your repetition is impaired. Your repetition is impaired. So, if I am drawing this diagram, so see, if this is vernix and this is Broca, and there are arcuate fasciculus attaching them, so vernix area will be gone, and some part of arcuate fasciculus is also gone. This will be vernix area. तो वर्निक अफेजिया में वर्निक्स एरिया भी अफेक्ट होता है एंड सम पार्ट ऑफ आर्कुड फेसिकुलस इज आल्सो अफेक्टेड, सम फाइबर्स आल्सो. दैट्स व्हाई वर्निक अफेजिया इज फ्लुएंट अफेजिया प्लस रेपिटेशन इज आल्सो इम्पेयर्ड इन वर्निक्स अफेजिया. ओके एवरीवन. नाउ विल कम टू अदर टाइप. सबको समझ में आ गया? गिव मी थम्स अप इफ यू हैव अंडरस्टूड कि वर्निक्स अफेजिया ब्रोका अफेजिया क्या है. ब्रोका नॉन फ्लुएंट प्लस रिपीटेशन इंपेयर्ड, वर्निक्स फ्लुएंट अफेजिया प्लस रिपीटेशन इंपेयर्ड. एवरीवन डन? हैव अंडरस्टूड टिल नाउ? जस्ट गिव मी थम्स अप. Everyone have till understood till now? Just give me a thumbs up. Then we'll proceed further. If any doubt, just tell me in comment section. I will repeat also again. Anyone, any doubt till now? Just tell me in comment section. Okay. Now we'll come to other. That is your trans transcortical motor aphasia. So what do you understand by transcortical motor aphasia? We understood that there was Broca aphasia, in which Broca's area plus your output facility was some part was also damaged. That's why repetition was impaired. In transcortical Broca aphasia, only okay, Dr. Vipul, I will be coming to your institute also. Only Broca area is gone. Only Broca area is gone. Only Broca area is gone. Okay. So if only Broca area is gone, so there will so there here so here repetition, your reputation is intact. Your reputation is so in transcortical motor fascia, your repetition is intact. In transcortical motor fascia, your repetition is intact. Okay, everyone. So if I draw a diagram like this, and suppose this is your Broca area, this is your Wernicke's area, and this is your arcuate fascicular. So only and only your Broca area is affected. Only and only your Broca is affected. Your Wernicke's is spared. Your Wernicke's is spared. Okay, everyone. Next is your transcortical sensory. Transcortical sensory aphasia. In this, only your Wernicke's area is affected. Only and only your Wernicke's is affected. So it means repetition is intact here. Repetition is intact here. Okay. See this diagram. If this is your Wernicke's, this is your Broca, and these are your arcuate fascicular. So in transcortical, only and only your Wernicke's is affected. Okay. Next is your third plus fourth mix. That is your transcortical, transcortical motor plus sensory. It is known as mixed transcortical. It is known as mixed transcortical. So it means repetition is repetition is intact here. रिपीटिशन क्या है यहाँ पे इंटैक्ट है. तो अगर हम डायग्राम ड्रॉ करेंगे तो कैसा ये ऐसा ये ब्रोका ये वर्निक्स इनको कनेक्ट कर रहा है एंड इट विल बी लाइक दिस ओनली ब्रोका गॉन एंड ओनली वर्निक्स गॉन बट योर आर्कुट fasciculus is spared. Other is your sixth is your conductive aphasia. Your conductive aphasia. In this arcuate fasciculus is damaged. क्या डैमेज है सिर्फ आर्कुएट फेसिकुलस डैमेज है तो ओनली प्रॉब्लम इन रिपीटिशन ओनली प्रॉब्लम इन रिपीटिशन ओके एवरीवन नेक्स्ट is your global aphasia. I will draw this diagram of see this were your Broca and this is your one next. If this is your arcuate fasciculus, so it will be like this. Only arcuate fasciculus affected. Okay, everyone done. Now comes your global aphasia. Global aphasia. In global aphasia, your Broca. Thank you, highly inflammable. So in global aphasia, your Broca plus your Wernicke's plus your arcuate fasciculus, all will be affected. All will be affected. So it is known as your global aphasia. See, this is a diagram. This is Broca. This is Wernicke's, and this is connecting them. Sorry, if this is arcuate fasciculus connecting them, so it will be like this. All will be gone. Done. Now there is something known as your anomic aphasia. There is something known as your anomic aphasia. Okay. In anomic aphasia, only naming is affected. Only naming is affected. क्या affect होता है only? Naming. Suppose if this is a pen, what I will say, it helps in writing, it is a white color, it is used in exams, but I will be not be able to say that it is a pen. So other than name, all things are normal, but I can't say name. So in anomic aphasia, only naming is affected. And in this, your angular gyrus is affected. Your angular gyrus is affected. So we all know that there's a the language pathway. It starts with Wernicke's area. ठीक है? And from Wernicke's area, some information goes to your angular gyrus also. Angular gyrus also, such that you can better understand the thing. For better understanding. For better understanding. And then from angular gyrus, it again goes to Wernicke's area. And from Wernicke's area, that's same. It will go to arcuate fasciculus and then to Broca's area. So Wernicke's area before transforming its signal to arcuate fasciculus, before giving his signals to arcuate fasciculus, it just in between consult with angular gyrus. It just in between consult with angular gyrus, such that there is a better understanding. And if there is angular gyrus is affected, it is known as your anomic aphasia, in which only naming is affected. Okay, everyone. सबको यहाँ तक समझ में आ गया? Shall we move forward? Just give me a thumbs up. Anyone having any doubt till now? So I am drawing a diagram, just telling the kind of aphasia. So if this is Broca and this is Wernicke's, and they're connecting with each other, done. So now tell me the now tell me the diagnosis. Tell me the diagnosis. Which type of aphasia is this? Which type of aphasia is this? Which type of aphasia is this? Just tell me. Anyone in comment section can tell me which type of aphasia is this? Anyone? Dr. Ayushi, highly inflammable. Dheeraj, can you tell me which type of aphasia is this? This is figure 1 and this is your figure 2. Tell me the diagnosis of figure 1 and figure 2. Anyone in comment section can tell me what is the diagnosis of figure 1 and what is the diagnosis of figure 2? Anyone? Yeah, very good. Figure 2, fluent aphasia. Which figure? Figure 1, figure 2, Harniklal. So, very good. Figure 1 is Wernicke's of fluent aphasia. In figure 1, only Wernicke's area is affected, but your arcuate fasciculus is spared. In figure 1, only only Wernicke's area affected. So, it is transcortical sensory. It is transcortical sensory. Okay, Harniklal, very good. Tell me figure 2. Tell me figure 2. Tell me your figure 2. Tell me the phase of figure 2. Harniklal, anyone? Figure 2. In figure 2, yeah, very good. It is your Broca area is affected and some part of arcuate fasciculus is also affected. What does this mean? It means it is in a Broca aphasia. It is in a Broca aphasia. And if it is like this, Broca and Wernicke's, and this is your arcuate fasciculus, and only Broca is affected. Only and only Broca is affected. Then it will be your transcortical motor aphasia. Then it will be transcortical motor aphasia because in this only Broca area is affected. No, better slowly. It will be transcortical motor, not sensory. Broca is all but motor now. Bro, transcortical sensory, it is figure 1. It is transcortical sensory because only one nix is gone. In figure 3, only your Broca is gone. So it will be transcortical motor. Okay, beta? Okay, beta? Shall we move forward then? आगे समझ slowly but surely. Just give me thumbs up if you have understood the figure 1, figure 2, figure 3, then we will move forward again. चले बेटा आगे आगे समझ में आपको okay so this is the table of Harrison. Okay, so this is the table of Harrison which tells about all the various type of aphasia. So we can see in this table that Harrison is telling to us that comprehension, repetition, naming, and fluency. So we have to check any aphasia in a four domain. There are four domains of language. four domains of language, and we have to check all aphasia in these four domains. What are these domains? This is your comprehension, this is your repetition, then is your naming, then is your fluency, then is your fluency. Okay, everyone. So there are four domains of language: comprehension, repetition, naming, and language. The most common domain which is affected, the most common domain which is affected is your naming. मोस्ट कॉमन कौन सा है आपका बेटा? नेमिंग. क्या है आपका? नेमिंग. या स्लोली. सो मोस्ट कॉमन कौन सा है आपका बेटा? नेमिंग. सो इन दिस फिगर यू कैन सी नेमिंग इज इम्पेयर्ड इन ऑल. नेमिंग इज इम्पेयर्ड इन ऑल एक्सेप्ट द लास्ट टू, except the last two, which is your pure word deafness and pure alexia, which is your pure word deafness and pure alexia. Except that naming is affected in all the type of aphasia. Except that naming is affected in all the type of aphasia. That's why in four domains of language, the domain which is always affected, which is maximum affected, is your naming. It is your naming. For and how to check all the domains? For comprehension, you have to check is the patient following your commands or not. For repetition, you will check, you will say something to that patient, and you will tell that patient to repeat. Naming, I have told you, you will give him object, you will tell him to name something. If he is able to name, good. If not, it is a naming. And fluency, in fluency, you will check the grammar, syntax, and how properly the patient is able to say something. That is your fluency part. So now we will compare each aphasia one by one. So first is your Wernicke's aphasia. So first is your Wernicke's aphasia. ठीक है. वर्निक अफेजिया में क्या इंपेयर्ड हो रहा है? कॉम्प्रिहेंशन. ओके, क्योंकि वर्निक अफेजिया किसके काम आता है? अंडरस्टैंडिंग काम आता है. ओके सर. रिपीटेशन क्यों? क्योंकि वर्निक्स अफेजिया में वर्निक्स एरिया के साथ साथ देयर इज सम डैमेज टू आर्कुअस fasciculus. दैट्स व्हाई repetition is also affected. Then comes naming. Naming is affected in all the type of aphasia I have told you. And fluency, it is preserved because Broca's area is attacked. Okay, everyone. Now we'll come to Broca's aphasia. In Broca, comprehension is preserved because Wernicke's area is not affected. That's why your comprehension is preserved. When it's come to repetition, because with Broca area, yeah, Hanik, we will come to this topic in upcoming slides. Okay, Hanik? Now, in Broca, when it's come to repetition part, because with Broca area, some part of outward fasciculus will be also gone. That's why repetition is impaired here. Naming is impaired in all of the flowing, and fluency will be decreased because Broca area is affected. Okay. Now third is global. In global, Broca, Wernicke's, Arcuate, all is gone. So your comprehension is also gone. Your repetition is also gone. Naming is affected in all, and fluency is also decreased. Then comes beta your conduction. Only in conduction, only your arcuate fasciculus is affected. Your arcuate fasciculus is affected. So your comprehension is preserved. Only and only your repetition is affected. Your naming is also impaired, but fluency is preserved because naming is impaired in all of the type of aphasia. Then comes your transcortical non-fluent. That is your motor. That is your motor. What does it mean? Only and only Broca is affected, but Arcus fasciculus is preserved. So, if only and only Broca is affected, comprehension will be preserved, your repetition will be preserved, naming is impaired in all aphasia, and your fluency will be impaired. Okay, beta. Next, come to transcortical sensory. In transcortical sensory, your Wernicke's is affected. Only and only one is your outward fasciculus is also spared. So comprehension is impaired. Only and only comprehension is impaired, and naming is impaired. Your repetition will be preserved, and your fluency will be preserved. Then comes your isolation aphasia. Your isolation aphasia is a mixed transcortical. It is a mixed transcortical. ठीक है बेटा. तो क्या होगा मिक्स ट्रांसकॉर्टिकल में? ब्रोका जाएगा, वर्निक्स जाएगा, बट आर्कुस फेसिकुलस क्या होगा? स्पेयर्ड होगा. तो कॉम्प्रिहेंशन भी impaired, repetition equalia. It means you will be repeating same thing again and again. So repetition is preserved here. Equalia or preserved. ठीक है बेटा. नेमिंग सब में impaired है, and fluency, no purposeful speech, fluency will be also impaired in this. Then comes your anomic aphasia. In this, all will be okay. Only and only your naming is impaired. Only and only your naming is impaired. Okay बेटा. आगे समझ में. तो फोर डोमेन्स में हमने सारे फेजिया के टाइप देख लिए. नाउ just tell me, if there is a patient, it is comprehension, repetition, naming, and fluency. In this patient, naming is affected. Okay. And in this patient, say comprehension is affected and repetition is affected and fluency is okay. Tell me which kind of aphasia is this? Only and only fluency is okay, and comprehension, repetition, naming, all three are affected. Tell me the kind of aphasia, because these kind of questions you will get in your NEETPG exam. Your comprehension is affected, your repetition is affected, naming is affected, all kind of aphasia except your pure word definite. In this, comprehension, repetition, naming, all are affected. Only and only your fluency is okay. Tell me which kind of aphasia is this? Anyone? Harnik Lal, slowly. Dr. Ayunshi, tell me the which kind of aphasia is this? Anyone? Anyone? Comprehension is affected, repetition is affected, naming is affected, and fluency is okay. Transcortical motor conductive aphasia. No, ना. Why transcortical? हर्निक, repetition भी तो गया है. Repetition भी तो गया है ना, तो transcortical तो हो ही सकता. In transcortical, arcuate fasciculus is preserved. So repetition is intact. So it can't be transcortical. Naming तो सब में जाता है. Repetition भी गया है, comprehension भी गया है. मतलब वर्निक्स एरिया भी गया है ना, आर्कुट fasciculus भी गया है. If वर्निक्स area plus arcuate fasciculus is affected, it is Wernicke's aphasia. It is your Wernicke's aphasia. Okay, Harnik, got this? Yeah, Samson, very good. It is Wernicke's aphasia. Case 2, comprehension, repetition, naming, fluency. In this, comprehension is okay, repetition is okay, naming is impaired in all, and fluency is also impaired. Tell me which kind of aphasia is this? Tell me which kind of aphasia is this? Anyone? Which kind of aphasia is this? Comprehension okay है, repetition okay है, naming तो सब में affected होती है और इसमें fluency भी affected है. Anyone? Samson, Harnik, which type of aphasia is this? बेटा you have to be fast ना. नीट पीजी में इतना टाइम नहीं मिलेगा हमको. हमें नीट पीजी में इतना टाइम नहीं मिलेगा. वी हैव टू सी फटाफट. सबसे पहले क्या देखना है? रिपीटिशन देखना है. अगर रिपीटिशन ओके है, इट मींस आर्कुट fasciculus ओके है. एंड इफ आर्कुट fasciculus इज ओके, देन वी हैव टू थिंक इन टर्म्स ऑफ ट्रांसकॉर्टिकल. ओके. अगर आर्कुट fasciculus अफेक्टेड है, वी विल थिंक इन टर्म्स ऑफ वर्निक aphasia, ब्रोका एंड कंडक्टिव. बट अगर रेपिटेशन ओके, इट मींस आर्कुट fasciculus ओके, then we'll think in terms of transcortical and transsensory. Transcortical motor, transcortical sensory. बिकॉज ब्रोका वर्निक अफेजिया में अगर ब्रोका अफेजिया है तो ब्रोकाज एरिया प्लस आपका आर्कोफेस्कुलर अफेक्टेड होता है. बट अगर ट्रांसकॉर्टिकल है, सपोज इट इज अ ट्रांसकॉर्टिकल मोटर टाइप, देन only your broca will be gone. Your arcuate will be spared in there. So tell me the diagnosis of this case. Anyone? Harniclas, Sampson, comprehension okay है, repetition okay है, naming affected है, fluency affected है. बेटा if repetition is okay, transcortical, transcortical motor, very good Harniclas, very good. Repetition okay है, repetition okay है, it means transcortical है, fluency affected है, only broca is gone. It means it is a transcortical motor. It is a transcortical motor. Very good Harniclas. No, Samson, it is not Broca. Agar it is a Broca aphasia, in Broca aphasia, Broca's area and some part of outward fasciculus is damaged. So in Broca's aphasia, there is always an issue in repetition. But in this patient, your repetition is normal. In this patient, बेटा आपका repetition क्या है? Normal है. तो अगर repetition normal है, it means outward fasciculus okay है. It means only and only Broca is gone. Only and only Broca is gone. So it is a transcortical motor type. Okay, Samson? See another case. Case 3. In this patient, comprehension okay है, repetition भी okay है, fluency भी okay है, सिर्फ और सिर्फ naming is affected. Tell me the aphasia. Tell me the aphasia. Case 3. Comprehension okay है, repetition okay है, fluency भी okay है, सिर्फ और सिर्फ naming is affected. Anyone? Tell me which kind of aphasia is this? Comprehension okay है, repetition okay है, fluency okay है, only बेटा naming is affected. Hani Clark Sampson, tell me which kind of aphasia is this? कैल्विन मिक्स ट्रांसकॉर्टिकल नो बेटा ना. मिक्स ट्रांसकॉर्टिकल अगर होता तो मिक्स ट्रांसकॉर्टिकल होता तो रिपीटिशन तो ओके होता, ठीक है, रिपीटिशन ओके होता. बट मिक्स ट्रांसकॉर्टिकल में आपका कॉम्प्रिहेंशन फ्लुएंसी गॉन होता ना, इसमें तो कॉम्प्रिहेंशन फ्लुएंसी दोनों ओके है. इट इज एन एनोमिक अफेजिया. ये आपका बेटा क्या है? एनोमिक अफेजिया इन विच एंगुलर गायरस इज अफेक्टेड. इन विच एंगुलर गायरस इज अफेक्टेड. इन विच एंगुलर गायरस इज अफेक्टेड. Okay, beta. In which angular gyrus is affected, only and only naming is affected. It is an anomic aphasia in which only and only naming is affected. बेटा केल्विन अगर ये मिक्स ट्रांसकॉर्टिकल जो मिक्स्ड ट्रांसकॉर्टिकल विच इज योर नेमिंग अफेजिया, विच इज योर नेमिंग अफेजिया, अगर ये होता तो क्या क्या होता? कॉम्प्रिहेंशन, रेपिटेशन, नेमिंग, फ्लुएंसी. नेमिंग इज इम्पेयर्ड इन ऑल. रेपिटेशन विल बी ओके क्योंकि ट्रांसकॉर्टिकल है. कॉम्प्रिहेंशन भी जाता, फ्लुएंसी भी जाती. ओके केल्विन. Now we will see all kind of aphasia again. See, we will start with sensory aphasia. We will start with sensory aphasia. First in your sensory aphasia is your anomic aphasia. Is your anomic aphasia. So anomic aphasia में क्या क्या होगा? हम यहाँ लिखते हैं comprehension, repetition, naming, fluency. Comprehension जाए तो comprehension नॉर्मल होगा, repetition नॉर्मल होगा, नेमिंग ही इंपेयर्ड होगी, फ्लुएंसी भी ओके होगी। तो एनोमिक अफेजिया, इन एनोमिक अफोजिया योर एंगुलर gyrus is affected. So there is only problem in naming. I suppose this is a pen, so I will be able to tell if this is used to write, this is used to this helps us in exam in writing. But I will be not able to say this is pen. Only and only naming is gone. This is your anomic aphasia. ठीक है बेटा? नेक्स्ट अब आते हैं नेक्स्ट aphasia पे. That is your conduction aphasia. That is your conduction aphasia. ओके. तो यहाँ साइड में चार डॉट करते हैं CRNF. तो नेमिंग तो सब में इफेक्ट होती है क्योंकि कंडक्शन है. इन कंडक्शन व्हाट इज कॉल्ड योर आर्कुएट फेसिकुलस. योर आर्कुएट फेसिकुलस इज अफेक्टेड. इट मीन्स योर repetition is also gone, but your comprehension and fluency is okay. ठीक है बेटा. और क्या होता है इसमें? इन कंडक्शन ऑफ एरिया वी हैव सीन दैट देयर आर पैराफेजिया. देयर आर पैराफेजिया. देयर इज पैराफेजिया. सो व्हाट डू यू अंडरस्टैंड बाय द टर्म पैराफेजिया? पैराफेजिया क्या मतलब होता है बच्चों? पैराफेजिया का मतलब होता है देयर आर सम अनइंटेंडेड वर्ड्स. देयर आर सम अनइंटेंडेड words in between the speech. There are some unintended words in between the speech. There are some unintended words in between the speech. देखो, we have to understand that paraphasia and there is something known as paraphasia and something known as your neologism. Neologism. In neologism, there are new words, but in paraphasia, it is not your new word. It is your old words only. There are no new words in it. No new words in it. Only unintended words in between speech. Only unintended words between speech. Suppose I'm take example. If suppose I have to say Ram, if I have to say Ram, I will say it as ma'am. I will say it as ma'am. So it looks like word Ram, but I have said it ma'am. Suppose if I have to say television, if I have to say television, I will be saying it television. I will be able to sing it is television. So why this is happening? It is due to incorrect due to incorrect word or sounds between the word. Just due to incorrect word, due to incorrect, just make it as alphabet. Okay, due to incorrect alphabet or sound between the word. So paraphasia क्या है? Paraphasia और neologism दोनों different है. Neologism में patient will say new words, but in paraphasia patient will not say new words. He will say words just like the word. मतलब he will say the word incorrectly, but the word which he will say it will look like that same word. So suppose I have to say pencil, I will say here ramsil. Pencil, ramsil. So in pencil, when I'm saying ramsil, what is look like? But in pen, I am saying ram. So there are some incorrect sounds or incorrect alphabets in paraphasia. Okay, everyone? Everyone has got the concept of paraphasia. In paraphasia, there can be incorrect sounds or incorrect words, but no new words are there. Words are old, but the words which you normally say, so we are instead of saying normal word, we are saying some words which look alike that words, but but we are changing that word with the help of some incorrect sounds or incorrect words. Okay, everyone? Okay with the concept of paraphasia? In conductive aphasia, there is a phenomenon known as paraphasia, in which there are unintended words in between speech or new words. So suppose have to say Ram, we will say ma'am. We have to say television, we will say television. So we are saying some look-alike words, but we are not able to say the correct word because some incorrect sounds or words are coming in between. Some incorrect sounds or words are coming in between. This is known as your paraphasia. Okay, again. Now we'll come to other type of. Now we will come to other type of sensory aphasia. That is your transcortical sensory aphasia. That is your ट्रांसकॉर्टिकल सेंसरी अफेजिया. तो सभी बच्चे उसका चार्ट बनाओ फटाफट. क्या चार्ट है बताओ. कॉम्प्रिहेंशन, रेपिटेशन, नेमिंग एंड फ्लुएंसी. ट्रांसकॉर्टिकल है तो रिपीटिशन क्या होगा, ओके होगा क्योंकि आर्टिकल फैसिकुलर इज सेव्ड. नेमिंग सब में अफेक्टेड होती है. सेंसरी है मींस वन इज गॉन, योर कॉम्प्रिहेंशन गॉन. फ्लुएंसी विल बी इंटैक्ट. डन. it generally happens it generally happens in watershed area, in watershed area where there are end arteries, suppose ACA and MCA water zone is there, they are both ending in a zone, so it is the watershed area. See, if this is a diagram and these are your ventricles, suppose these are your ventricles, okay, so this is area of ACA, this is area of MCA, and this is area of PCA. Then beta, and this is your watershed zone. This is your watershed zone. This is your watershed zone. Just from anterior horn of lateral ventricle and atrium of lateral ventricle, atrium that is posterior part of lateral ventricle, draw two lines diagonal. Draw two lines diagonal, and you will be able to get area ACA, MCA, and PCA. Okay, and the area between AC and MC, it is the watershed area. So transcortical sensory aphasia generally happen in watershed area. Okay, and what are the reason? That is your most common reason is your hypotension. Most common reason is your hypotension. Next is your Wernicke's aphasia. Next is your Wernicke's aphasia. So just draw diagram: comprehension, repetition, naming, and fluency. Naming is affected in all. Done. Repetition, yeah, because in Wernicke's aphasia, with Wernicke's area, some part of arcuate fasciculus will be also there. So repetition will be gone. If Wernicke's area is affected, can you able to understand all things? No. So comprehension is gone. Only fluency is okay. Only fluency is okay. So if there is a patient of Wernicke aphasia and you will say him to raise his hand, he will be not be able to raise his hand because he is not understanding things. He is not understanding things. But his Broca area is okay, so he will be able to speak. He will be speaking like anything, and he will be angry with the surroundings because he is saying words to you, but he is saying words, but he is not understanding things now. So he will be angry with you all because you are all the surrounding people will be like कि क्या बोल रहा है, गलत बोल रहा है, कुछ भी बोले जा रहा है. But he is like, I'm saying some everything. He is not understanding, so he will be angry to you because he will not understand the situation. So one of the patient are generally patients who are angry because they are not able to understand the things, and they perceive that they are understanding things, but outside people are not understanding him. That's why they always will be angry. So if you tell a patient with aphasia to raise his hand, he will not be able to raise his hand because his comprehension is not intact. But he will be able to say things. So he himself will be saying many words. He himself will be saying many words because his Broca's area is intact. He will be fluent. He will be fluent, but he will not follow your command. He will not understand what you are saying. Okay, बेटा. सब कुछ समझ आ गया. वर्निक्स अफेजिया में क्या हो रहा है? वर्निक्स अफेजिया में कॉम्प्रिहेंशन, रिपीटिशन, नेमिंग सब अफेक्ट है. फ्लुएंसी सिर्फ ओके. सिर्फ आपकी फ्लुएंसी पार्ट ओके. So when you will say something to him, he will not able to understand. He will formulate words. He will say new words with his own self. With his own self, he will not understand what you are saying. He will not understand your commands also. But he will be able to speak word and he will be saying nonsense word और नॉनसेंस सेंटेंसेस ऑल द टाइम. सो वर्निक्स में क्या क्या हो रहा है? देयर इज पैराफेजिया. We all have understanding about paraphasia. In our last slide, we have understood what is paraphasia. Other is your neologism. What do you understand by neologism? He will say new words. He will say new words which has not exist till now. Which has not exist till now. And this kind of speech is known as jargon speech. It is known as, sorry, it is known as jargon aphasia. ठीक है? So he will sing some words to you. New word. Hachi kuchi. Hacho kuchi. Do you understand this word? No. There is no meaning of this word, but he will say. So he will say paraphasia and he will say as well as neologism. He will say new words. And no one will be able to understand this kind of word. He will be like hochi kochi, meteorology, kaingana, achi kochi, watigonga, wanganga, ingorga. So he will sing some new words or new languages which anyone in his surrounding will not be able to understand. Everyone okay till now? Have you understand about one is aphasia? There will be paraphasia, neologism. He will be angry with his surroundings because you will be saying something to him. He will be not be understanding that thing. You will be like, "Bhai, kya hai, kuch samajh nahi aa raha," and he will sing words to you, and he will be saying new words. You will be not able to not to understand. So he will be angry with the surrounding. He will be like कि मैं बार बार बोल रहा हूँ बट ये समझ क्यों नहीं रही क्योंकि वो तो न्यू वर्ड बोल रहा है क्योंकि वो तो न्यू वर्ड बोल रहा है एंड वो आपकी कमांड भी फॉलो नहीं कर पाएगा वो ही विल बी लाइक दैट व्हाई ही स्पीकिंग टू मी अगेन एंड अगेन why he is speaking to me again and again. Okay, beta, just give me thumbs up if this part of one page is clear. So see what Harrison has to say. Gestures and panetone do not improve communication. The patient may not realize that his or her language is incomprehensible and may appear angry and impatient with the examiner. He will angry impatient with the examiner. Okay. And suppose you are sitting in a casualty and patient is coming to you and he is saying new words to you. He is saying some new words to you. He is saying some new words to you. Okay. There is a patient in your casualty or emergency and he is saying some new words to you. New words. Okay. And he is coming to in casualty. He's like "Khwache, khwachi, ruan chumalaya, ye wahan chalang gaya, wang gaya, wang gaya." He is saying some uttering words to you. So what you will think? You will think, yeah, ये कोई psychiatric issue तो नहीं है. Is this patient psychiatric or not? So many a times, many a times, Wernicke's aphasia, Wernicke's aphasia has a differential diagnosis of psychiatric illness. So if patient is saying some new words to you, either you will think it is a Wernicke aphasia or you will think it is a psychiatric illness. So it is important for you to distinguish between Wernicke's aphasia and psychiatric illness. It is important for you to distinguish in emergency. If patient is saying new words, so many times he will be uttering words. His relatives will be thinking that something psychiatric issue is there, and patient will be coming casualty. You will be thinking it is a psychiatric issue. A MBBS will think it is a psychiatric issue. A MD resident will think either it can be a Wernicke aphasia or it can be psychiatric illness. But a DM resident, a DM neurology will be able to identify that it is a Wernicke aphasia patient. And we will see how will be. First is your history. First, you have to take a proper history. Then, what Harrison is saying that the ability, the ability to follow command, which is aimed at axial musculature, may be preserved. Means command which we giving to his axial musculature, commands which are giving to axial musculature is preserved. So there is a dissociation between the failure to understand simple question that what is your name, he will be not able to understand because his one area is gone, comprehension is gone. So if you will ask me what is your name, he will be not be able to understand. But the when patient is asked to rapidly close his eyes, sits up or roll over, when you ask him to close your eyes, sit up or roll over, he is able to do this. He is able to do this. It is a characteristic of one aphasia and helps differentiate it from deafness, psychiatric disease, or malingering. Okay, Arya? So there is a dissociation between the failure. There is dissociation between the failure to understand simple question patient who rapidly follows the commands of axial musculature. It means there's a patient of Wernicke aphasia. If I will ask him simple question, close your, I will ask him what is your name. I will ask him raise your hand. He will be not be able to understand these things. But if I ask him to close his eyes or to roll over the bed or to sit up, where you have to use your axial musculature, he will be able to follow this command. So Wernicke aphasia patient don't understand anything, but when you give him commands of specially related to axial musculature, he will be following this command. That is the important feature of Wernicke aphasia, and that's how whenever you are sitting in emergency, you will be able to differentiate between is this a patient of Wernicke aphasia or malingering by asking him to follow some commands related to axial musculature. Okay, everyone, got this? Just give me thumbs up. अगर ये समझ में आ गया कि वर्निक aphasia के पेशेंट को साइकेट्रिक इलनेस से वर्निक aphasia के पेशेंट को साइकेट्रिक पेशेंट को कैसे डिफरेंशिएट करना है, because many times Wernicke aphasia patient are labeled as psychiatric patient and they are roaming here and there. So you just have to check about axial musculature command. If patient is following that command, just order an MRI or CT scan. You will get an infarct in the temporal part. Okay, beta. ये बात सबको समझ में आ गई? Just tell me in comment section if you are able to understand that how should we distinguish between Wernicke aphasia and psychiatric illness. Just tell me in comment section. अगर हमें ये समझ में आ गया कि वर्निक अपेजिया को कैसे डिस्टिंग्विश करना है साइकेट्रिक इलनेस से. वर्निक अपेजिया patient will be will be able will be able to follow will be able to follow the commands related to axial musculature. ठीक है. There's the dissociation between the failure to understand simple question in a patient who rapidly closes his or eyes, sits up and or rolls over when asked to do so. So one aphasia patient will be able to follow the command related to axial musculature, but psychiatric patient psychiatric patient will not follow any command, even related to axial musculature. Even related to axial musculature. Anyone, any doubt? If अगर ये समझ में आ गया है कि इमरजेंसी में कैजुअलिटी में कोई साइकेट्रिक पेशेंट आता है या वर्निक एफिजिया का पेशेंट आता है, कैसे डिस्टिंग्विश करना है, सबको समझ में आ गया, जस्ट गिव मी थम्स अप, देन वी विल मूव फॉरवर्ड. जस्ट गिव मी थम्स अप अगर आपको ये बात समझ में आ गई कि साइकेट्रिक पेशेंट को कैसे डिस्टिंग्विश करना है. एवरीवन, everyone is clear with this concept, how to distinguish between a Wernicke's aphasia patient and a psychiatric patient. Everyone, shall we move forward, beta? क्या सबको समझ में आ गया कि वर्निक अफेजिया के पेशेंट को और साइकेट्रिक पेशेंट को कैसे डिस्टिंग्विश करना है? एवरीवन, ओके बेटा, कंसेंट. नाउ वर्निक्स अफेजिया वर्निक्स अफेजिया generally वर्निक अफेजिया patient and Broca aphasia patient. Suppose there are two patients, Wernicke aphasia and Broca aphasia. What we have seen that Broca aphasia is damaged when there is damage to superior division of middle cerebral artery, and Wernicke aphasia is damaged when there is inferior division of MCA is damaged. And when superior division of MCA is damaged, then there is also a contralateral weakness. Then there is also a contralateral weakness. It means कि अगर वर्निक अफेजिया का पेशेंट होगा तो उसको वीकनेस कभी नहीं होगी, और ब्रोका का अफेजिया का पेशेंट होगा तो उसको हमेशा कॉन्ट्रेक्टल वीकनेस होगी ही होगी. तो अगर पेशेंट को वीकनेस है कॉन्ट्रेक्टल, इट मींस मैक्सिमम चांसेस को ब्रोका अफेजिया होगा. और अगर ऐसा पेशेंट है जिसको कॉन्ट्रेक्टल वीकनेस नहीं है और साइकेट्रिक की पेशेंट की प्रेजेंट कर रहा है, इट मींस वो वर्निक अफेजिया होगा, क्योंकि वर्निक अफेजिया में इंफीरियर डिवीजन डैमेज होता है मिडल सेरिब्रल आर्टरी का, और ब्रोका में सुपीरियर डिवीजन डैमेज होता है. तो सबको बात क्लियर है. ब्रोका अफेजिया प्रेजेंट विद कॉन्ट्रोलेटरल वीकनेस एंड वर्निक्स प्रेजेंट विदाउट वीकनेस. वर्निक्स प्रेजेंट विदाउट वीकनेस, विदाउट वीकनेस. ठीक है बेटा. तो अब देखते हैं कैसे होता है. वी आर सीइंग दिस इज द ब्लड सप्लाई ऑफ ब्रेन. ये है हमारा एंटीरियर सेरिब्रल आर्टरी. ठीक है. ये हमारा मिडल सेरिब्रल आर्टरी, और ये हमारा पोस्टीरियर सेरिब्रल आर्टरी. ठीक है. तो वी आर सीइंग दैट मिडल सेरिब्रल आर्टरी इज सप्लाइंग द whole lateral part of brain, whole lateral part of brain, and this is your Broca, this is your Broca. Done. And this is your Wernicke, this is your Wernicke. This is your Wernicke. It means middle cerebral artery is supplying both the area. It is supplying Broca, it is supplying Wernicke as well. Okay, it is clear that middle cerebral artery is supplying Broca, it is supplying Wernicke. And middle cerebral artery, when it is passing, it divides in two parts: a superior division and inferior division. Its superior division supplies Broca's area, and its inferior division supplies Wernicke's area. Okay, now see, we are seeing this diagram. This is your internal carotid artery. Done. It is dividing into middle cerebral artery and anterior cerebral artery. That your middle cerebral artery, as it is going, it is dividing into two parts. That is your MCA superior division and MCA inferior division. ठीक है. MCA inferior division is supplying to temporal lobe. ये क्या है बेटा आपकी? ये तो temporal lobe है. So MCA inferior supplying to temporal lobe, supplying to temporal lobe. और टेम्पोरल लोब में आपका क्या है बेटा? टेम्पोरल लोब में तो वर्निक्स एरिया है. टेम्पोरल लोब में ही तो आपका वर्निक्स एरिया है. दैट्स व्हाई कि वर्निक्स एरिया के डैमेज से आपको क्या मिलता है? वर्निक अफेजिया. ठीक है. और एमसी सुपीरियर डिवीजन ये किसको सप्लाई कर रहा है? इट इज सप्लाइंग फ्रंटल एंड पेराइटल लोब. इट इज सप्लाइंग फ्रंटल एंड पेराइटल लोब. एंड आपका ब्रोकाज एरिया कहां पे है? फ्रंटल लोब में. इसलिए आपको डैमेज मिलता है ब्रोकाज एरिया का सुपीरियर डिवीजन से. एंड फ्रंटल कॉर्टेक्स में आपकी क्या होता है? मोटर कॉर्टेक्स होता है. क्या होता है आपका? मोटर कॉर्टेक्स होता है. इसलिए एमसी सुपीरियर डिवीजन जो फ्रंटल और पेराइटल दोनों को सप्लाई करती है, क्योंकि फ्रंटल लोब का डैमेज होता है, तो इसलिए आपको कॉन्ट्रोलेटरल वीकनेस मिलती है. क्यों मिलती है? क्योंकि फ्रंटल लोब में तो ब्रोकाज एरिया भी है, तो ब्रोका एफेजिया मिलेगा. साथ में फ्रंटल लोब इज ऑल्सो हैविंग द मोटर कॉर्टेक्स. So if motor cortex is involved, then you will get weakness also. That's why superior division of MCA, which is supplying your frontal as well as parietal lobe, it leads to Broca's aphasia plus contralateral weakness, because primary motor cortex area is affected. And from primary motor cortex area is your corticospinal tracts are originating. And in your temporal lobe, in temporal lobe, are corticospinal tracts are there in temporal lobe? No. Corticospinal tract are in your frontal lobe and in your parietal lobe. But in temporal lobe, there are no corticospinal tracts. So when temporal lobe is affected, when Wernicke aphasia is there is no weakness, because no corticospinal tract is coming from temporal lobe. No corticospinal tract is coming from temporal lobe. Then beta, we can write that corticospinal tract, it comes from frontal lobe, and 40% comes from parietal lobe. Done. But none of them comes from temporal lobe, but none comes from temporal lobe. So if inferior division, which is supplying temporal lobe, if it is affected, if Wernicke phase is there, can there be weakness? No, there can't be weakness because corticospinal tract doesn't originate from temporal lobe. सबको समझ में आ गया यहाँ तक? Just give me a thumbs up अगर यहाँ तक सबको समझ में आ गया. If you have understood till now, just give me a thumbs up. Now see, this is MCRT. If you see the superior division, it is going upward. If this is a sulcus, artery above this superior, below this is inferior. So this is are your inferior, which are going to this area. That is your Wernicke's area. And see, this is your Broca, and this area is your motor cortex. This is your motor cortex. Okay? And from motor cortex also cortex spinalis come, and cortex spinalis also come from parietal lobe. Okay, beta? So if there is M2 inferior division, M2 inferior division, that is your MCA inferior division, it will lead to temporal lobe gone. It will lead to temporal lobe gone. ठीक है? तो क्या होगा? It will lead to Wernicke's aphasia, and plus weakness will be not be there. There can be superior quadrantopia. सुपीरियर क्वाड्रेंटोपिया, बिकॉज टेम्पोरल लोब के पास ऑप्टिक रेडिएशन भी है, बिकॉज योर ऑप्टिक रेडिएशन फाइबर्स आर इन पैराइटल लोब एज वेल एज इन टेम्पोरल लोब. If optic radiation fiber of temporal lobe are affected, then there is superior quadrantopia. So you can get Wernicke aphasia, and with it you can get superior quadrantopia. ठीक है? अगर M2 superior division is affected, M2 superior division is affected, ठीक है? क्या इफेक्ट है M2 superior division और MCA superior division? What does it mean? It means Broca aphasia plus contralateral weakness. Plus contralateral weakness. Done. And there will be inferior quadrantanopia. ये क्यों होगा बेटा? क्योंकि पैराइटल लोब की वजह से ये होगा, पैराइटल लोब की वजह से, बिकॉज सम ऑप्टिक रेडिएशन फाइबर गो टू पैराइटल लोब, एंड कॉन्ट्रालेटरल वीकनेस क्यों होगी? इट इज ड्यू टू कॉर्टिकोस्पाइनल ट्रैक्ट. एंड कॉर्टिकोस्पाइनल कहां से आ रहे हैं? कॉर्टिकोस्पाइनल ट्रैक्ट इज कमिंग फ्रॉम योर frontal lobe as well as from parietal lobe, as well as from parietal lobe. Done. सबको यहाँ तक समझ में आ गया? जस्ट गिव मी थम्स अप इफ यू आर एबल टू अंडरस्टूड टिल नाउ. जस्ट गिव मी थम्स अप अगर M2 सुपीरियर डिवीजन में ब्रोका फेज जाएगा, एंड ब्रोका फेजिया में ही कॉन्ट्रेक्टल वीकनेस होगी, बट इन वर्निंग अफेजिया कॉन्ट्रेक्टल वीकनेस विल बी एब्सेंट. इफ यू आर एबल टू अंडरस्टूड टिल नाउ, जस्ट गिव मी थम्स अप. इफ एनी डाउट जस्ट टेल मी कमेंट सेक्शन. अगर यहाँ तक किसी को कोई भी डाउट है, जस्ट टेल मी इन कमेंट सेक्शन. Anyone, any doubt till here? Just tell me in comment section. Shall we move forward then? Now suppose if I am saying your MCA main division is affected, your MCA main division is affected, it means superior plus inferior, both division gone. It means both divisions are gone. It means Broca area is gone, Wernicke's area as well is gone. So it will lead to global aphasia. will lead to global aphasia. Then with it, it will lead to contralateral weakness. Then other thing it will lead to, yeah, Samson, what confusion? Just tell me in conversation, क्या confusion है बेटा? Just tell me, क्या समझ नहीं है बेटा आपको? Yeah, Samson, can you tell me in which part you are having confusion? See, I will repeat. देखो बेटा, आपका वर्निक्स अफेजिया और ब्रोका अफेजिया है, ठीक है? बोथ वर्निक्स एंड ब्रोका आर बी सप्लाइड बाय मिडल सेरेब्रल आर्टरी. डन, अंडरस्टूड, ठीक है. Characteristic feature is that Wernicke's aphasia occurs without weakness, but Broca aphasia is always it is with weakness. Now we will see why. Middle cerebral artery is dividing into two parts: MCA superior division and MCA inferior division. Your MCA superior division goes to frontal and parietal lobe, and inferior division goes to temporal lobe. In temporal lobe is your Wernicke's area. In frontal is your Broca's area. Done, sir. Now, your corticospinal tract, which are responsible for weakness, they only originate from frontal and parietal lobe. They only originate from frontal and parietal lobe. So it means they doesn't originate from temporal lobe. They doesn't originate from temporal lobe. So if it is a Wernicke's aphasia, if temporal lobe is damaged, can you get contralateral weakness? No, contralateral weakness will not be there. ठीक है? But when it is a superior division, your superior division supplies frontal as well as parietal lobe. Your superior division, better see, your superior division supplies frontal as well as parietal lobe. And if this is your lobe, this is your frontal and parietal lobe. Suppose this is your frontal lobe and this is your parietal lobe. Then this is your motor cortex and this is your somatosensory cortex. In parietal is the somatosensory cortex and frontal is your motor cortex. Both of these leads to corticospinal tract. Corticospinal tract leads in both of these cortex matrix originate. So cortex matrix is coming some from frontal and some from parietal lobe. Cortex matrix कहाँ से आ रहा है? Frontal lobe से भी आ रहा है, parietal से भी आ रहा है. So if there is damage to superior division, which is supplying frontal and parietal lobe, your cortex tract will be also damaged. Your cortex tract will be also damaged. That's why in Broca's aphasia you get weakness. Okay, Samson. I think it is now clear. Okay, Samson. Just tell me in comment section. Okay, Samson. Now cleared. Now MCA, both main division is affected. It means superior plus inferior. Both divisions are gone. So global aphasia will be there. Contralateral weakness will be there. There will be contralateral hemisensory loss. Why? Because parietal lobe is affected. Because parietal lobe is affected. And your ascending tract, anterior spinothalamic tract, and your dorsal column, they go in which lobe? They go in parietal lobe and they decussate. So they go in parietal lobe. That's why there will be contralateral hemisensory loss if parietal lobe is affected. And there will be there will be contralateral homogeneous homogeneous hemianopia. Why? Because as your parietal lobe is gone, as your parietal lobe gone, so it leads to inferior. It leads to inferior quadrantopia. And as your temporal lobe is also gone, as your temporal lobe is also gone, it leads to superior quadrant anopia. And if we combine both inferior and superior, it leads to homogeneous hemianopia. Done. So global aphasia, contralateral weakness, contralateral hemisensory loss, and contralateral homogeneous hemianopia. Done, everyone. Shall we move forward? Okay. Now we have understood that Broca aphasia will come. Broca aphasia, weakness, contralateral. Wernicke aphasia, no weakness. Okay, everyone. Shall we move forward? Broca aphasia, weakness, contralateral. Wernicke aphasia, no weakness. Now we will come to motor aphasia. Now we will come to motor aphasia. ठीक है बेटा. मोटर aphasia में first is your transcortical motor aphasia. ठीक है. अब ट्रांसकॉर्टिकल मोटर aphasia में क्या होगा? जस्ट चार्ट ड्रॉ करते हैं. कॉम्प्रिहेंशन, रेपिटिशन, नेमिंग, फ्लुएंसी. नेमिंग तो सब में जाती है. डन. एज इट इज ट्रांसकॉर्टिकल, आर्कुड fasciculus विल बी नॉर्मल. तो रिपीटिशन क्या होगा? नॉर्मल. ट्रांसकॉर्टिकल मोटर है, मींस ओनली ब्रोका इज गॉन, तो फ्लुएंसी इज अफेक्टेड, कॉम्प्रिहेंशन इज डन. आ जाते हैं अगले फेजिया पे. अगला फेजिया कौन सा है? अगला फेजिया है मेरा, अगला है मेरा ब्रोका फेजिया. अगला फेजिया क्या है मेरा? ब्रोका फेजिया. ब्रोका फेजिया में क्या है? कॉम्प्रिहेंशन, रेपिटिशन, नेमिंग एंड फ्लुएंसी. Broca phase means Broca area plus some part of arcuate fasciculus is gone. It means repetition is gone, naming सब में जाती है, fluency is gone, only comprehension is intact. Only comprehension is intact. And patients say only limited words, and yes or no. Patient generally say limited words, बहुत ही limited words only, and that is especially your yes or no. Now, see what Harrison is trying to say. Uh, it is saying that additional neurological deficit include right facial weakness plus hemiparesis or hemiplegia, which I have told you that in patient of Broca aphasia there is weakness. Okay. Now, even when spontaneous speech is dysarthritic, the patient may be able to display a relatively normal articulation of words when singing. This dissociation has been used to develop specific therapeutic approaches of for Broca's aphasia. What do you understand by this? Suppose I am a patient of Broca aphasia. I am a patient of Broca aphasia, and I am sitting with my friend. I am sitting with my friend. My friend is like he is not able to speak, and suddenly what happens to me? A beautiful girl is crossing to me. A beautiful girl is crossing to me, and I will be like I will be singing a song. I will be singing a song like हुस्न तेरा तौबा 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 तौबा. And my friend will be like, Arya, yaar, he was not able to speak, but now he's singing a song. He was not able to speak, but now he's able to sing a song. Why this is happening? He will go to doctor and he will tell, sir, he is singing a song, but he's not able to speak. So he was like, it is because of girl. No, it is not because of girl. It is because that what scientists have seen that in a patient of Broca aphasia, speech is affected, but some part of the singing is preserved. So in therapy, when we are doing speech therapy of Broca aphasia patient, we use singing as one of our treatment procedure. We use singing as one of the treatment procedure. So a patient of Broca aphasia, if I compare a patient, this is a normal and this is a patient of Broca aphasia. Then when it's come to normal speaking. When it's come to normal speaking, if normal, if it is a normal, he can speak 100% correct. But Broca only 10% correct. Only 10% correct. But when it comes to singing, normal patient can 100% sing, but a Broca aphasia can sing around 30 to 40%. He can sing. So in Broca aphasia patient, singing is little bit preserved as compared to spontaneous speech. So when suppose I am a patient of Broca aphasia and my friend is sitting beside me, I am not able to speak anything. But when a beautiful girl is passing to me, Broca aphasia patient will be singing a song like Husn Tera Tauba 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 Tauba. Okay, everyone, have you got? In Broca aphasia patient, little bit of singing is preserved, and this singing we use it also as a treatment of in patient of Broca aphasia. Okay, everyone, just give me a thumbs up if you understood this part. Just give me a thumbs up. Everyone has got this part. Just give me a thumbs up if you understood this part. कि ब्रोका फेजिया में थोड़ी बहुत सिंगिंग पेशेंट कर सकता है, स्पीक तो कर ही नहीं पाएगा, बट ही कैन डू लिटिल बिट ऑफ सिंगिंग. ओके, कैन यू मूव फॉरवर्ड? सबको समझ में आ गया कि ब्रोका फेजिया पेशेंट, a patient of Broca aphasia can sing a little bit, can sing little bit, can sing little bit, but can't speak, but can't, but can't speak fluently, but can't speak fluently. ठीक है बेटा, सैमसन स्लोली गॉट दिस कंसेप्ट. हर्निक लाल कैलविन. चलो नेक्स्ट. नेक्स्ट इज योर, नेक्स्ट इन मोटर फेजिया इज योर आइसोलेशन अफेजिया. नेक्स्ट इज योर आइसोलेशन अफेजिया. आइसोलेशन अफेजिया में क्या है? इट इज इन ए मिक्स्ड ट्रांस cortical aphasia. It is a mixed transcortical aphasia. So, comprehension, repetition, naming, fluency. Naming सब में खराब होगी because it is transcortical, तो repetition ओके होगा. एंड इज मिक्स्ड मीन्स ब्रोका भी गया है, वन एक्स भी गया. ठीक है. लास्ट इज योर ग्लोबल. Last is your global, in which everything is affected: comprehension, reading, naming, fluency. Gone, 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 and gone. ठीक है. So we will see now what Harrison is saying. In isolation aphasia, it represents a combination of two transcortical aphasia. We know it is a mixed and sensory. Comprehension is severely impaired and there is no purposeful speech. Okay. The patient may parrot fragments of heard conversation, that is no equalia, indicating that neural mechanism for repetition are at least partially intact. It means Wernicke भी गया, Broca भी गया, but he will be repeating command, he will be repeating everything like a parrot. जैसे तोता बोलता है ना, क्योंकि आइसोलेशन ऑफ एजिया में सिर्फ रेपिटेशन इज इंटैक्ट. आइसोलेशन ऑफ एशिया में क्या इंटैक्ट है? सिर्फ रेपिटेशन इंटैक्ट है. तो जैसे तोता बोलता है, इट विल बी लाइक स्पीकिंग, रिपीटिंग ऑल द थिंग्स अगेन अगेन, लाइक पेन 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 पेन, लाइक अ पैरेट. दैट इज नोन एज इकोलिया, इकोलेलिया. दैट इज नोन एज इकोलेलिया. So he will be like chanting, repeating all this again and again like a parrot, because in isolation aphasia, all things is gone except your repetition is preserved here. So I think You all have understood this table very much clearly, na? Uh, in a short, this is a short diagram to understand things in much more clear manner. See, first is above the diagonal line is your poor repetition. Below this line is your good repetition. So poor repetition is your Broca and conduction. Good, sir. Then good repetition. Go- and poor repetition is also Wernicke's aphasia. In Wernicke's aphasia, conduction aphasia, Broca. In both, Arcus fasciculus is affected. That's why poor repetition. Then, sir, good repetition. Transcortical motor, mixed transcortical aphasia, and transcortical sensory aphasia. Because in transcortical aphasia, your arcuate fasciculus is not affected. It is normal. So repetition is preserved. So it is good repetition. Then comes fluent and non-fluent. In non-fluent speech, it means Broca area is gone. So either it can be a Broca aphasia, or it can be a transcortical motor aphasia, or it can be a mixed transcortical aphasia. Then, sir, then comes fluent speech. It means Broca is okay, but Wernicke is gone. So, in which condition can be? First is your conduction aphasia. In conduction aphasia, output fasciculus is not there. So, if you can't repeat, you in conduction aphasia, you can repeat everything. You can repeat as well as you can speak because your Broca's area is intact. That's why fluent speech. No, sorry, in conduction aphasia, sorry, beta, there is non-fluent and fluent. In fluent speech, your Wernicke's area is affected, but your Broca's area is okay. So in conduction aphasia, your output fasciculus is affected, but Broca is okay, na? So you can speak. You can speak. In Wernicke aphasia, only your Wernicke's area is affected. Your Broca's area is okay. You can speak. In transcortical sensory, also your Wernicke's area is affected, but Broca's area is okay. You can speak. In conduction aphasia, your Broca as well as Wernicke all were okay. Broca as well as your Wernicke all were okay. So you can speak. Then comes your good comprehension. It means your Wernicke should be okay, such that you can understand things. In conduction, Wernicke is okay, you can understand things. In Broca, aphasia, Wernicke is okay, you can understand things. In transcortical motor, Wernicke is okay, you can understand things. Poor comprehension means your Wernicke is gone. In Wernicke aphasia, Wernicke is gone. In transcortical sensory, Wernicke gone. And in mixed transcortical aphasia, also your Wernicke gone. Everyone, सब कुछ समझ में आ गया डायग्राम? Everyone okay? So we have finished dominant lobe disorder. We have finished the dominant lobe dominant lobe disorder. Now we will come to non-dominant lobe non-dominant lobe language issue. Non-dominant lobe language issue. ठीक है? Now we all know we have two lobes, right lobe and left lobe, and we have seen that left lobe is good for mathematics, calculation, language, but right lobe is used for singing, story narration. For singing, your right lobe is used. So when your non-dominant lobe is damaged, what kind of language issue will be there? So when your non-dominant lobe is damaged, there is something known as your dysprosody. Dysprosody. क्या होता है बेटा? Dysprosody. It means if non-dominant lobe is damaged, your emotional part, your emotional part in speech, your emotional part in speech will be affected. Your emotional part in speech will be affected. Means suppose if 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 I am here giving you a lecture and I am speaking monotonously, like I go to suppose I go to bathroom, then after bathroom I went to playing. After then in playing, I scored 100 runs. In 100, out of this, 50 runs are scored in boundary. So, is there any motion? No. This is dysporosity. It happens in non-dominant lobe of type of lesion. It is dysporosity. Suppose someone cracks a beautiful joke, but still I am not laughing. Still I am not laughing. So my emotional component is gone. My emotional component is gone because when we say something to someone, there is some emotional component, there is some emotional gesture into it. There is some emotional component, emotional gesture into it. But these kinds of patients will speak a monotonous, a same tone. Whole sentence they will speak in a same tone. Like, I am going to park. Then after that, I will go to home. In home, I will sleep. After sleeping, I will wake up after 3 or 4 hours. Then I will take a bath. After taking bath, I will sit for study. So see, is there any emotional component? No, it is a monotonous type of speech. So this is your dysporosity. This happens in a non-dominant type of lesion. It happens in a lesion when there is a non-dominant lobe is affected. When your non-dominant lobe is affected, especially most of the time it is your right hemisphere. Most of the time is your right hemisphere. ठीक है बेटा? Till now, any doubt? Understood about non-dominant lobe? सबको non-dominant समझ में आ गया? Is everyone is okay with this? डोमिनेंट लोब नॉन डोमिनेंट में क्या होगा बेटा डिस्पोरेसिटी इसमें इमोशनल कंपोनेंट ऑफ जो स्पीच होगा वो अफेक्टेड होगा सिर्फ और सिर्फ इमोशनल बाकी ऑल पार्ट ऑफ लैंग्वेज विल बी ओके बट यू कांट कन्वे द इमोशनल पार्ट ऑफ योर लैंग्वेज बिकॉज वी नीड सम जेस्चर we manipulate our tone according to our emotions because if you are crying you will be like oh क्या हो गया मैं रो रहा हूं so you manipulate your tone in your emotional way but in this you will not your emotional component will be absent okay everyone तो किसी को डाउट है एफेजिया पार्ट में जस्ट टेल मी कमेंट सेक्शन और देन वी विल मूव फॉरवर्ड इज एवरीवन ओके विद एफेजिया पार्ट जस्ट टेल मी if you are okay with the aphasia part then we will move forward so after completing aphasia anyone having any doubt in aphasia part dominant lobe broca Wernicke aphasia global aphasia in non-dominant lobe it will be dysporosity in dysporosity emotional component is affected which component is affected your emotional component in dysporosity okay now we will move to parietal lobe parietal lobe disorders okay in parietal lobe it is divided into two parts that is first is your dominant lobe dominant and non-dominant it is your dominant and non-dominant ठीक है बेटा parietal lobe में दो parietal lobe के when we are speaking about parietal lobe we speak in two one is the dominant lobe and other is your non-dominant lobe ठीक है so now we will see कि dominant lobe के dysfunction में क्या होगा और non-dominant lobe के dysfunction में क्या क्या होगा so when is your when it is about your dominant lobe first is beta is your supra marginal gyrus क्या होता है supra marginal gyrus if this is affected if this is affected it leads to apraxia it leads to apraxia and what do you understand by term apraxia it means inability inability to carry out a voluntary motor act a voluntary motor act in the presence of in the presence of normal motor or sensory system ठीक है what do you understand by this it means everything is okay everything is okay there is no kind of weakness but still you are not able to carry the motor component still you are not able to carry the motor component suppose if I want to lift this pencil I will raise this pencil above but if I am not able to raise this pencil and there is no weakness it means it is an apraxia it means it is an apraxia so inability to carry out a voluntary motor act in the presence of normal motor sensory system. Suppose if I am not able to make chapati, if I am not able to make chapati, and I am able to do all the kinds of things, but I am only not able to make chapati, it means it's a type of apraxia. It is a type of apraxia. Generally, it happens in a particular task. Suppose I am not able to do chapati, or I am not able to dress myself. Suppose I am wearing pant above and shirt below. So it is kind of dressing apraxia. I am able to do everything, but I am not able to perform this particular act. So apraxia means everything is okay, but you are still not able to do a particular motor act. This is your apraxia. And when your dominant lobe is affected, and in dominant lobe, the supramarginal gyrus is affected, two kinds of apraxia are seen. That is your ideational apraxia and is your ideomotor apraxia. So what do you mean by term ideational apraxia? Ideational apraxia means that idea is not coming. That idea is not coming. Suppose if I if I want to go to play cricket, if I want to go to play cricket, so in my mind the idea should come. First, in my mind, idea should be coming so that I should go to play cricket. But idea is not coming. That is your ideational apraxia. And what is your ideomotor? The idea which is coming in your mind, it is not getting converted into a motor act. The idea which is coming into your mind is not getting converted into a motor act. It is your ideomotor apraxia. Suppose if ideas coming to mind in my mind is coming to play cricket, but still I am not able to play cricket. It is your ideomotor apraxia. So in ideomotor apraxia, the idea is coming, but it is not implementing into a motor act. And in ideational apraxia, idea is not coming. In ideational, idea is not coming. In ideomotor, it is not converting into a motor act. Okay, everyone. Koi doubt? Just tell me comment section. Second beta is your angular gyrus. Second is your angular gyrus. So just like a supramarginal in which there is apraxia, if your angular gyrus is affected, it leads to agnosia. It leads to agnosia. What it leads to? It leads to agnosia. What do you mean by the term agnosia? It is inability to recognize any object by touch or vision or sound in the presence of normal visual sensory function. Okay, beta. There is inability to recognize object by touch or vision or sound. This is your agnosia, and it is affected in your case of angular gyrus. So in angular gyrus, there is your agnosia. There is your agnosia. Okay? We all have studied above that when angular gyrus is affected, first is there is was your anomic aphasia. There is your anomic aphasia. There is your anomic aphasia. Other thing is when angular gyrus is affected, it is your Gerstmann syndrome. Is your Gerstmann syndrome. It is your Gerstmann syndrome. And what is the mnemonic? It is PDA. It is PDA. Okay. In Gerstmann syndrome, it is in parietal lobe. It is in parietal lobe. And that's also in dominant part. That's also in dominant part. And which part is affected? It is your angular gyrus. It is your angular gyrus. So Gerstmann syndrome, mnemonic is PDA. P stands for parietal lobe, D for dominant, and A for angular gyrus. Anyone? Any doubt till now here? Samson, Harniklal, anyone beta? Any doubt? So When your angular gyrus or dominant lobe is affected, there is anomic aphasia, and other thing is your Gerstmann syndrome. And what are the components of Gerstmann syndrome? Can anyone tell me the components of Gerstmann syndrome? It is your tactile agnosia, means I am touching the pencil with my eyes open, but still I am not able to identify this is the pencil. This is your tactile agnosia. Other is beta your acalculia. It means 2 plus 4. I am not able to tell. 2 plus 4, I am not able to tell. It is your acalculia. Other beta, other is your finger agnosia. Other is your finger agnosia. It means, suppose if I am touching my this finger, I will be able to tell this is my ring finger and it is my index finger, it is my middle finger. But in finger agnosia patient is not able to tell which is his ring finger, which is his index finger. That is your finger agnosia. Other, other is your beta right to left disorientation. It means he's always confused which is right, which is left. If I have given him a gloves, if I have given him a gloves and I am telling him that wear this glove is in right hand and wear this part of glove in left hand, so he will be always confused which to wear in right, which to wear in left. So there is right to left disorientation. Other is your beta, it is alexia without agraphia. What do you mean by alexia? It means loss to read, loss to read. And what is the mnemonic to remember Gerstmann syndrome? What is the mnemonic? It is, it is, it is star. What do you call a star? You call it Tara. You call Tara. E stands for tactile agnosia. A stands for acalculia. Other A stands for alexia. R stands for right to left disorientation. And if tactile agnosia is there, then there will also be a finger agnosia. ठीक है? So Gerstmann syndrome first mnemonic is PDA. पहला mnemonic क्या है बेटा? PDA means patent ductus arteriosus, means P से parietal lobe, D से dominant lobe का लीजन है, A से angular gyrus affected होता है Gerstmann syndrome में. What is the mnemonic of components of Gerstmann syndrome? It is star. That is your Tara. Tara. T stands for tactile agnosia, A stands for acalculia, A stands for other A is for alexia, and R is for right to left disorientation. Okay, everyone. Anyone till now any doubt? किसी को डाउट है डोमिनेंट लोब के अंदर, डोमिनेंट लोब में क्या क्या होगा? एप्रेक्सिया होगा और एग्नोसिया होगा. एप्रेक्सिया में कौन सा एप्रेक्सिया होगा? एडिशनल और आइडियोमोटर. और एग्नोसिया में क्या क्या होगा? एनोमिक अफेजिया होगा और जेस्टमैन सिंड्रोम होगा, जिसका निमोनिक क्या है? तारा. सबको समझ आ गया? तारा. किसी को डाउट? चलो मेरे साथ. तारा. टी से टेक्टाइल एग्नोसिया, ए से ए कैलकुलिया, आर से राइट टू लेफ्ट डिसोरिएंटेशन एंड ए से एलेक्सिया विदाउट ए ग्राफिया. एलेक्सिया विदाउट ए ग्राफिया. Okay, Harniklal, anyone till now any doubt? Just tell me in comment section. Anyone till now here any doubt? सबको समझ में आ गया? जेस्टमैन सिंड्रोम का निमोनिक क्या है? तारा एंड पीडीए. कहां पे होंगे? डोमिनेंट लॉब में, एंड एंगुलर गायरस विल बी अफेक्टेड. ओके एवरीवन. Now, in parietal lobe, we will come to non-dominant lobe. Non-dominant parietal lobe feature. Non-dominant parietal lobe feature. And that most of the time is your right parietal lobe. Most of the time. Most of the time. ठीक है बेटा? So, first feature that we will studying will be your hemispatial neglect. Hemispatial neglect. What do you mean by hemispatial neglect? It means neglecting one half of your body. It means neglecting one half of your body. That is your hemispatial neglect. ठीक है? अब क्या होता है? See, there is your right hemisphere. There is your right hemisphere, and other is your left hemisphere. Other is your left hemisphere. Your right hemisphere take into account your right and left extra personal space. Right and left extra personal space. But your left hemisphere take into account only right extra personal space. It means your right extra personal space is taken into account by both right and left. But left extra personal space is only and only taken into about your right hemisphere. So if right hemisphere is damaged, your left extra personal space is gone. So maximum time hemispatial neglect is of left side. Maximum time, because your right space is controlled by both right and left, but only left is controlled by one. So maximum time your hemispatial neglect hemispatial neglect will be of left side. Will be of left side. So if anyone is thinking that this patient is suffering from hemispatial neglect of right side, you should again think of your diagnosis. You maybe not be you can be wrong also. Maximum time hemispatial neglect will be on left side because your left extrapersonal space is controlled by only one hemisphere, but your right extrapersonal space is controlled by two hemisphere, right and left. Your left extrapersonal space is controlled by only one hemisphere. So if you are getting hemispatial neglect, maximum chances are that it will be of left side. It will be of left side. Everyone got this? Just give me a thumbs up अगर समझ में आ गया. If you have got this concept कि हेमिस्पेशियल नेग्लेक्ट जो होगा मैक्सिमम टाइम वो लेफ्ट साइड का ही होगा. वो किसका होगा मैक्सिमम टाइम? लेफ्ट साइड का ही होगा. Okay, now see this. If this is a guy and I am telling to this person that just copy these items, just copy करना है. क्या करना है? हमें copy करना है. And this is a watch, this is a home, and this is a flower. ठीक है? And ये क्या है? This is the right side, this is the left side. Done. And he is copying, but he is not copying the left side. See, he is not copying the left side. He is not copying the left side. He is only copying the right side. This is your hemispatial neglect. When you tell him to copy something, he will copy only right side. He will not copy left side. Other thing, it is your spontaneous drawing. It is your spontaneous drawing. You are telling him that just draw a face of anyone. Just draw a face of anyone. So what you are seeing that he is drawing the right face, but he is not drawing the left face. He is not drawing the left face. When you tell him to draw a watch, he is drawing the right side, but he is not drawing the left side. He is not drawing the left side of watch. Okay. He will be combing. When he is combing, he will comb only right side. He will not comb to left side. He will comb only right side. He will not comb to left side. And he will be his face will only maximum time will be towards the right side. He doesn't he doesn't know that there is something some body part here. He doesn't recognize that this hand, this left hand is of me. Suppose I am a patient of non-dominant parietal lobe. I am a patient and I am suffering from hemispatial neglect. What I will be thinking that whose hand is this? It is not my hand. This left hand is not my hand. My hand is right hand. and this side of my body I will be not recognizing this side. I will be only maximum time I will be facing the right side. So this is the hemispatial neglect. When someone is saying copy to me, I am copying only right side. When someone is saying to me think and draw something, then also I am drawing thing on right side. And if I'm combing, I am combing on right side. I'm not combing left side. I'm not taking care of my left side. This is hemispatial neglect, which happens in non-dominant lobe lesion. ठीक है? See, this is a diagram in Harrison, left and right. This patient was told to encircle the A. This patient was told to encircle the A. He's encircled all the A's on the right side. He's encircled all the A's on right side, but he has left the A's on left side. He has left the A's on left side. This is a diagram from Harrison. Okay, beta. And there are two bedside tests that are useful in assessing the neglect. That is your simultaneous bilateral stimulation and your visual target cancellation. Your visual target cancellation. So this diagram which I was seeing to you, it is a diagram of visual target cancellation. And what do you understand by terms simultaneously bilateral stimulation? Suppose if I am standing and I am suppose I am suppose I am a patient of have a special neglect. And suppose if someone is coming to me, he's clicking something to right side and someone is clicking to me left side. I will be able to know stimulus of right side. I will be able to know how this is a stimulus from right side. But when someone is doing stimulus on left side, I will be not able to recognize that stimuli. I will be not able to recognize that stimuli. I will be able to recognize right stimuli, but not left stimuli. Okay? And this is the visual target cancellation. Someone told me to encircle the A's of right side, but I am a patient of hemispatial neglect. I will encircle only the A's on right side, not on the left side. ठीक है बेटा? Now, after hemispatial neglect in non-dominant lobe is your second is your constructional apraxia. Is your constructional apraxia. It means not able to draw, not able to draw 3D figures, not able to draw 3D figures. Suppose this is a patient of constructional apraxia. I have told him to draw a star. See what he is drawing. I am. I have told him to draw what. See what he is drawing. So this is your constructional apraxia. He is not able to draw a 3D image. If I am telling him to draw a cube, suppose this is a cube, and I am telling him to draw a cube, he will be not be able to draw a cube. He will be like this. He will drawing this type of squares. Okay, everyone. Any doubt? Hanik Lal, any doubt? Slowly, Samson. Just tell me in comment section if anyone is having any doubt till now. So see, if I am telling him to draw star, he is drawing only lines. He is drawing only lines. This is your constructional apraxia. This is your constructional apraxia. Now, after constructional apraxia is your dressing apraxia. It is your dressing apraxia. It means you are not able to dress properly. If someone has told you to get for a ready for a party, you are wearing shirt in your legs and pant in your hands. This is your dressing apraxia. Then is your visual spatial disorientation. Visual spatial disorientation. It means problem in navigation. It means problem in navigation. It means visual spatial disorientation means problem in navigation. So I am living in my house for a long year, for 30, 40 years, but now I'm not able to recognize which is bathroom, which is toilet. If someone is saying to me, go to bathroom, I'm going to kitchen. So My navigation is lost. If I am driving, I am not able to get back to my home. So this is visual spatial disorientation, which navigation part is affected. And last but not the least is your anosognosia, in which person is not knowing his illness. Person is not knowing his illness. ठीक है? तो आपके नॉन डोमिनेंट लोब फीचर्स क्या क्या है? नॉन डोमिनेंट लोब फीचर्स क्या क्या है? फर्स्ट इज योर हेमिस्पेशियल नेग्लेक्ट. फर्स्ट इज योर हेमिस्पेशियल नेग्लेक्ट. देन इज योर constructional apraxia, then is your dressing apraxia, then is your visual spatial disorientation, and fifth is your anosognosia. And how to remember this? It is your mnemonic. What is the mnemonic to remember this? It is cash. It is cash. C से क्या है? Constructional, constructional apraxia. ठीक है? A से क्या है? Anosognosia. S से क्या है? Spatial disorientation. Spatial disorientation. एंड H से क्या है? H से है हेमिस्पेशियल नेग्लेक्ट. H से क्या है? हेमिस्पेशियल नेग्लेक्ट. एंड कैश कितने वर्ड्स का है? कैश 4 वर्ड्स का है. CASH. तो 1 2 3 4 वर्ड्स. तो 4 वर्ड्स मीन्स D. एंड फॉर D स्टैंड्स फॉर ड्रेसिंग एप्रेक्सिया. D स्टैंड्स फॉर ड्रेसिंग एप्रेक्सिया. ठीक है? सबको समझ में आ गया? निमोनिक, कैश निमोनिक. नॉन डोमिनेंट लोब के पीछे जाते हैं क्या निमोनिक है? कैश. सी फॉर कंस्ट्रक्शनल एपरेक्सिया, ए फॉर एनोसोग्नोसिया, एस फॉर स्पाइटल स्पेशियल डिसोरिएंटेशन, एंड नेक्स्ट फॉर हेमिस्पेशियल नेग्लेक्ट. और कैश में कितने वर्ड्स है? 4 वर्ड्स है. 4 वर्ड से क्या हो गया? डी. डी से क्या हो गया हमारा? ड्रेसिंग एपरेक्सिया. ठीक है? तो अगर हम कंपेयर करें पैराइटल लोब में डोमिनेंट वर्सेस नॉन डोमिनेंट लोब, तो देयर विल बी फिंगर एग्नोसिया है, एग्राफिया है, राइट लेफ्ट कंफ्यूजन है, ए कैलकुलिया है, ए प्रेक्सिया है, जो जेस्टमैन सिंड्रोम का पार्ट है. और ए प्रेक्सिया जो सुप्रा मार्जिनल का पार्ट है, उसमें कौन कौन सा प्रेक्सिया है डोमिनेंट लोब में? इट इज योर आइडिएशनल एंड अदर इज योर आइडियोमोटर. अदर इज योर आइडियोमोटर. एंड व्हेन इट कम्स टू नॉन डोमिनेंट लोब, इट इज योर नेग्लेक्ट ऑफ लेफ्ट साइड, हेमिस्पेशियल नेग्लेक्ट, योर कंस्ट्रक्शनल एप्रेक्सिया, and your visuospatial disorientation. ठीक है बेटा? These are the differences of your parietal lobe versus dominant versus non-dominant parietal lobe. यहां तक सबको समझ में आ गया? किसी को कोई डाउट? Anyone till now? Any doubt? Just tell me in comment section. Samson, Harnik, anyone? Any doubt? All clear? चले बेटा आगे चले. किसी को कोई डाउट पैराइटल लोब में डोमिनेंट और नॉन डोमिनेंट में डिफरेंस क्या है? निमोनिक, नॉन डोमिनेंट का निमोनिक है कैश. डोमिनेंट का निमोनिक क्या है? डोमिनेंट लोब का निमोनिक क्या था बेटा आपका? डोमिनेंट लोब में आपका था एप्रेक्सिया और एग्नोसिया. और एग्नोसिया में आपका क्या था? जेस्टमैन सिंड्रोम. और जेस्टमैन सिंड्रोम का निमोनिक क्या था? पीडीए और तारा. पीडीए और तारा. ठीक है? वी विल एंडिंग आवर क्लास विद द लास्ट सिंड्रोम, दैट इज योर बेलियंट सिंड्रोम. दैट इज योर बेलियंट सिंड्रोम. दैट इज योर बेलियंट सिंड्रोम. It is when there is a parieto occipital damage. When there is a parieto occipital damage. This syndrome happen when there is a parieto-occipital damage, and that also bilateral. So when there is a bilateral parieto-occipital damage, there is a syndrome known as Balint Balint syndrome. It is your Balint syndrome. It has three parts. That is your ocular apraxia, optic ataxia, and your simultanagnosia. Ocular apraxia, optic ataxia, and simultanagnosia. So we'll study one by one. First beta is your optic ataxia. ठीक है. ऑप्टिक एटेक्सिया में क्या है? विजुअल फील्ड इज ओके. योर विजुअल फील्ड इज ओके, बट यू आर not able to fix on a object. You are not able to fix on a object. There is hand eye in coordination. There is hand eye in coordination. Suppose if this is my object, and if I want to hold this pencil, but due to optic ataxia, I will be not be able to hold this pencil. Suppose this is a pencil, I think I'm a okay person, I will be catching this pencil like this. But if I am having optic ataxia, there is hand-eye incoordination. So if I am going to catch this pencil, I will be like this. I will be not be able to catch the pencil. This is your optic ataxia. Okay, बेटा. नेक्स्ट है आपका ऑक्यूलोमोटर एप्रेक्सिया. क्या है बेटा नेक्स्ट आपका? ऑक्यूलोमोटर एप्रेक्सिया. इन दिस योर थर्ड नर्व इज ओके. योर थर्ड नर्व इज ओके. थर्ड नर्व आपकी क्या है? ओके है. और थर्ड नर्व इज नॉर्मल, but it is not able to do its function. But still, it is not able to do its function. And occur problem occurs especially in saccadic movement. In saccadic movement, we all know what is saccade. Saccades are jumping of eyeballs to see a particular object. Suppose I am sitting and from this my right side someone is coming, so my eye will suddenly move to left side. Will suddenly my eye will suddenly move to left side to see that person. This is a saccadic movement. Okay, what is saccadic movement? Rapid jumping of your eyes, especially in horizontal gaze, to see a particular object. ठीक है. So my eyes, if someone is coming from my right, my eyes will immediately will shift to left to see that person. So saccadic are rapid jerky movements. Saccadic are rapid jerky movement in horizontal plane. In a horizontal plane. Now, if suppose these are my eyes, ठीक है, and I want to look to right side. I want to look right side. So, and this is my right eye and this is my left eye. So my right eye will be in abduction mode, and my left eye will be in adduction mode. If I want to look to right side, my right eye will be in abduction mode and left eye will be in adduction mode. And left side for adduction, what will be using? Using your MR, middle rectus, and MR is controlled by third nerve. But right now, I am having oculomotor apraxia. So if something is coming to right side, instead of seeing this, what I will do? I will see my like this. I will see like this. This is oculomotor apraxia. Why I'm seeing like this? Because my third nerve is not working. If my third nerve is working, I will be seeing like this. If someone is coming from right, I will seeing like this. My eyes will suddenly will jump to right side. If someone is coming from right side, my eyes will suddenly jump to right side to see this that object. But as I am suffering from oculomotor apraxia, my third nerve is not working. So to see someone from right side, my what I will do like this. I will do like this. Suddenly will move my whole neck to right side. This is your oculomotor apraxia. Okay, in oculomotor apraxia, if I am having oculomotor apraxia and someone is coming from right side, I will do like this. This is oculomotor apraxia. Okay, beta. Now, last part of Balint syndrome is your simultanagnosia. Your simultaneous, your simultanagnosia. Simultanagnosia. That is your last part. So, what do you understand from simultanagnosia? So, in this, problem. There is problem in integration. There is problem in integration of center and periphery field. Periphery field. Now, see, simultanagnosia means if you are seeing something, suppose I am seeing a forest. I am seeing a forest. So I am seeing there is there is one thing. First is your central. This is my visual perspective. Anything coming this is center, and everything surrounding me it is my peripheral. So the thing which is in my visual zone, the thing which is in my visual zone is my central zone, and thing all surrounding me is in my peripheral zone. Now, if I'm seeing a forest, if I'm seeing a forest, as there is a problem in integration of central and peripheral field, there is a problem in integration of central and peripheral field. That's why I I will be not be able to make a complete picture, not be able to make a complete picture, not be able to make a complete picture. So if I am standing in a forest, I will be seeing a particular tree, but there are various trees. If I if I was able to see a various trees, I will be calling it as a forest. But as my center and peripheral integration is not proper, as my center and peripheral integration is not proper, so I will be not be able to make a complete picture. I will be not be able to make a complete picture. What is complete picture? Complete picture is lot of trees, and lot of trees means forest. But now, as I can't make a complete picture, I am seeing only a one tree. So I will call it as a tree, not as a forest. I will call it as a tree, not a forest. So it is also known as missing the forest. What it is known as? Missing the forest for the trees. Missing the forest for the trees. Missing the forest for the trees. Because I am not able to make a complete picture. Suppose right now I'm sitting in my studio. What I'm seeing? I'm seeing my camera. I'm seeing there is a room. In room there is a gate. So this is a complete picture. So what is the complete picture? Complete picture is it is a studio room. Complete picture is that it is a studio room. But if I am suffering of simultanagnosia, what I will say? I will say in this room it is only a camera. It is only a camera because this camera is coming only in my visual perspective. Only camera is coming. My periphery and central part are not integrating with each other. So I will be only seeing that camera. So I will be seeing it is a camera, not a room, because my there is a disintegration between my central gaze and peripheral gaze. Normally, if my central and peripheral gaze is okay, my central I am seeing camera. From my periphery, I am seeing whole room. So my central and periphery will mix, and information will go to my mind that it is a studio room. But now my central and peripheral is not working. So I am seeing only central. Peripheral, I am not vision is not peripheral picture is not coming. In central picture only it is a camera and mobile phone. So I will say camera and mobile phone. This is happening when I am standing in a forest. When I am standing in a forest, only I am standing against a particular tree. So my in my vision only there is one tree. But if my peripheral vision is but if my peripheral picture is also okay, if my peripheral picture was okay, it will come into my mind that there are a lot of trees. So I will call a forest. But now my peripheral picture is not okay. Only central vision, only I am seeing through my visual gaze, and it is seeing only a particular tree. So it I will say it is a tree. Okay, beta. इन साइमल्टेनोग्नोसिया क्या हो रहा है, देयर इज अ डिसइंटीग्रेशन हो रहा है बेटा सेंटर का और पेरिफेरी फील्ड का। ठीक है, तो अगर मैं फॉरेस्ट में खड़ा हूं, मेरे सामने एक पेड़ है, ठीक है, मेरी पेरिफेरल से मेरे को बाकी पेड़ भी दिख रहे होंगे, अगर मैं बाकी पेड़ भी देख लेता तो मैं क्या बोलता, ये फॉरेस्ट है, ये ट्री नहीं है। बट क्योंकि मेरा पेरिफेरल फील्ड में और सेंट्रल फील्ड में डिसइंटीग्रेशन है, तो जो मेरे को दिख रहा है बस मैं वही बोलूंगा खाली। तो मेरे को खाली एक पेड़ दिख रहा है तो मैं पेड़ बोलूंगा, बट मैं फॉरेस्ट को नहीं बोलूंगा। ओके, दिस इज नोन एज मिसिंग द फॉरेस्ट फॉर द ट्री। जैसे मैं यहां बैठा हूं, मेरी आंखों के सामने सिर्फ मेरा फोन है, ठीक है, मैं बोलूंगा सिर्फ इस रूम में क्या है, फोन है। बट अगर मेरा पेरिफेरल भी ओके होता तो मैं बोलता इट इज अ स्टूडियो रूम, नॉट अ कैमरा। सबको समझ आ गया साइमल्टेनोगोनिया का मतलब क्या है? एवरीवन गॉट व्हाट डू यू अंडरस्टैंड बाय टर्म साइमल्टेनोगोनिया? It means there's a problem in integration of central and peripheral field, and you are only seeing the thing which is coming in front of your eye. Only you are not combining the peripheral things to make a complete picture. You are not combining the peripheral things to make a complete picture. So see this diagram. In this, in Harrison, this picture is seen. In this picture, we have drawn A's. There are some big A's. These are your big A's, and these are your small A's. But now you are able to see only big A, not a small a. Okay. Now, when a normal human being will encircle, he will encircle first big A. But this patient of simultanagnosia will encircle only small a, not big A. Why? Because when he is seeing a big A, when he is seeing a big A, suppose this is a big A, and if I am a patient of simultanagnosia, I am not seeing this big A. I am seeing only these lines. I am seeing only these lines. I am seeing only these lines, not a complete A. So the big picture, the big A. So the big A doesn't fall in my vision. Only lines are coming in my vision. Only lines are coming in my vision. So big A is not coming in my picture. Only lines are coming in my picture. That's why I'm not encircling a big A. But when there is a small A, when there is a small A, it is completely falling on my gaze. That's why this is such a huge paradox. If a normal patient would be there, he will first encircle the big A, not a small a. But this patient simultanagnosia is encircling small a, not a big A. Why? Because when he's seeing big A, he is not seeing big A. He is only seeing the lines. Because he only sees the thing which is coming in his gaze, and in his gaze, only lines are coming of big A's, not a big A whole is coming, because he's not able to mix the center and periphery picture. But when he's seeing a small A, this whole A is coming in front of his gaze. That's why he's encircling the small A, not a big A. Okay, everyone. सबको समझ में आ गया साइमल्टेनियस क्या है? If anyone still any doubt, just tell me in comment section. Okay. Good night. Thank you.